Good afternoon, everyone. Thank you for joining us for Adherence 2020 virtual pre-conference on continuity of HIV care in the context or in the presence of COVID-19. I wish we were meeting under better circumstances, but we're all responding in one way or another to the significant pain and suffering caused by the COVID-19 pandemic in almost every region of the world. We've assembled an incredible faculty joining us from various parts of the world to discuss different aspects of the COVID-19 response, but also the importance of ensuring a continuity of HIV care so that we do not lose momentum in the global fight against HIV, but also so that our patients, both those who are positive and negative, are receiving the best quality care possible. As many of you are aware, Adherence 2020 was scheduled to have taken place in June of 2020, but as with many live events, we've had to postpone it to November of this year. We felt very strongly, though, that in addition to sharing COVID-19 information, that there were key presentations from Adherence 2020 that could not wait until November to be presented, that are important for improving and enhancing the HIV care continuum to allow for optimal HIV treatment adherence and optimal HIV services. And so I'm very pleased that we've gathered this incredible and distinguished faculty. And I'll start with just some brief welcome remarks. First, to review the program, we will review what we need to know about COVID-19 and HIV, the importance of managing mental health conditions within the context of COVID-19, experiments in implementing telemedicine in a COVID-19 environment, this coming from colleagues in one of the epicenters of the COVID-19 pandemic, New York City, assuring continuity of HIV services in African countries, represented by one of the largest providers of services on the continent. Then we'll swing to HIV COVID-19 inequities and community resilience, optimizing ART adherence within disrupted health systems. U equal U as an important message to be communicated in normal times, but especially now in the midst of COVID-19 to promote HIV treatment adherence. And finally, the importance of communities as pathfinders in humanitarian emergencies. Next slide. Why are we concerned? So I'm sharing with you preliminary data, and we'll have more soon, about why we as an association are concerned about the impact of COVID-19 within the HIV space. We recently conducted a survey of our broad membership. We have over 30,000 members globally. And among those who responded, we identified that 56% of those respondents indicated that they are now managing COVID-19. So there's a significant repurposing of the HIV health workforce that is of concern to us and important to ensure continuity of care is creating the space for the types of innovations we'll be addressing today, including differentiated service delivery. As important, we asked our clinician members about disrupted HIV and related services. Here I highlight the top 5 from the survey as of this morning. And you'll note that there are some significant concerns, particularly in relation to mental health, viral load testing, and HIV case management. Next slide. The last 2 sets of data I'll share with you are concerns that our clinician members expressed. First, in relation to increased sexual and or other risk taking. You'll note here in orange, 44% of our clinician respondents were moderately concerned, 40% were very concerned about additional risk taking, and that may increase over time given the length of the COVID-19 pandemic. Finally, as many of you know, where disaggregated data are available related to COVID-19 infections as well as outcomes and mortality, there are significant racial disparities that have been noted. Here you'll see data related to our clinician member concerns about racial disparities. 47% of respondents indicated they were very concerned, and 29% were moderately concerned. That may increase over time, certainly as additional disaggregated data are available. Next slide. So with those opening remarks, I'd like to acknowledge our distinguished faculty, our institutional and corporate supporters, my staff, of course, for the rapid pivot to virtual meetings, and every clinician, allied health professional, and community worker out in the field who are doing heroic work in managing COVID-19 and or maintaining the continuity of HIV care. Please know we're deeply grateful. Finally, in the next slide, I would ask that you consider, if COVID allows it, to join us at Adherence 2020 in November of this year in Orlando. We have extended the call for late breaker abstracts. The submission portal will reopen June 1st through 5th. And abstracts must be submitted by 5 p.m. Eastern Daylight Time that day. There are 5 tracks in the conference, and so we ask you consider submitting within these. The 2 newest tracks are implementation science and the importance of community engagement. Finally, the Fast Track Cities 2020 conference is still scheduled to take place September 7th through 10th of this year in Lisbon. The focus is on urban HIV, TB, and viral hepatitis responses. But of course, within the context of COVID-19, we've added a keynote panel on COVID-19 and the metropolitan condition in a truly unpredictable world. And as important, we added a new abstract category specific to COVID-19 responses. The abstract submission deadline is, as with adherence late breakers, June 5th of this year. With that, I'll turn it over to my colleague and dear friend, Dr. Shannon Hayter, the Deputy Executive Director for Program at the Joint United Nations Program on HIV/AIDS. We're honored to have her with us to share a message of solidarity. Thank you very much.
Great, thank you so much, Jose. And I'm really here just to kick things off to be able to say thank you to everyone who is on this session today. I can see we have almost 300 people already today. And I know everybody is joining here most likely because you are on the front lines, figuring out solutions, committed to care, sharing information, and sharing lessons learned in real time with each other. So thank you for the work you're doing to really work towards continuity of HIV care for so many people around the world in many different but also many shared contexts. Next slide. And I always want to start by reminding us the scale of why we're here. And when we look at where we want to be by 2020, the global targets that every country in the world has signed on to, we want to see fewer than 500,000 AIDS-related deaths, which is still a lot, 500,000 people per year. And at the end of 2018, we were partway there. We still had nearly 800,000 deaths per year. And now, even as we hoped we were going to make those further gains, even as we should keep our commitments to continuing to reduce these deaths, we know COVID-19 changes the context. Recent modeling through Imperial College that was released on the 1st, just one model estimated a 10% increase in HIV-related deaths for the next 5 years based on short-term 3 to 6 month treatment interruptions alone. Now, it's our job together holistically to make sure that that modeling and the natural history of that is not what happens. And I know that the solutions you are all practicing day in and day out are going to help us avoid that modeled scenario from being truth, and instead definitely recommit to reducing our numbers and meeting our targets on the way to 2030. Next slide. And so really mirroring many of the things that Jose already mentioned, just wanted to touch on a few different issues that are probably going to come up across the speakers, across the city to country examples, and just really share the fact that these are issues, these are approaches that the entire global community is dealing with together and learning together. Slide. So a few things. First, as UNAIDS, we really wanted to start in our resources on what do people say they want, what do people say they need. Many of you are asking these questions day to day to the clients you're engaging. We've been able to reach out through our country offices in over 80 countries, through our established relationships with networks of people living with HIV and others affected by HIV, and say, you know, what do you need in terms of information on COVID and communications and engagement? What do you need for COVID prevention? What do you need for HIV treatment and service continuity? What do you need for mental health supports? What are you experiencing? And no doubt, one of the main responses that have come up from all the countries that have implemented these are people are concerned with their HIV treatment continuation. They're concerned about not having enough medication on hand, not knowing what they'll do if their clinic is closed down, not knowing how to really avoid interruptions because of lockdowns and healthcare services being overwhelmed. But that's not the only thing that people are concerned about. And this just shows me Indonesia, where there were concerns about health support, networks of sex workers coming together to provide creative solutions to reach out, support, and help each other cope with stress. So our community-led groups are in fact the partners with our more formal healthcare providers in crafting the solutions to what people say they need. Next slide, please. And so to take this one step further, a little bit of delay in the slide movements. You know, it's really highlight and what can we and should we be drawing upon for community-led organizations and community-led resiliencies as partners with the formal healthcare system, as part of the expanded healthcare system. You know, and when we say community-led, this is the best example of our core HIV principles of JIPA and NEPA, meaningful involvement of people living with HIV. So when we say community-led, we mean organizations are by affected people for affected people. And even in COVID, especially in COVID, this is a model for where people affected should be participating in the governance, in the dialogue, and the decisions, and the designs. If there are restrictions, then what needs to go with restrictions to make sure people's livelihoods and health are minimally compromised. Community-led involvement in service delivery, and I think everybody on the call probably knows community solutions to help extend treatment services, drug distribution have been key for partnership with facilities. And then finally, community-led monitoring, making sure at community level that things that have been promised, services that have been defined are actually happening and they're not interrupted and they're happening with quality. These are the things that more than ever we need to be able to promote, to tap into, to rely on in partnership during the COVID times. Next slide. And I think what you'll hear a lot today is currently a lot of the work that you are doing to make sure HIV service continuation, whether it's for treatment or for prevention, this really is all about expansion of flexible models, of differentiated service delivery, of ensuring that some of the practices that we've seen work in smaller situations are now and finally, hopefully, taken to scale. This includes issues like multi-month dispensing, ensuring that individuals have enough drug on hand that they can continue treatment even during times of transportation, shutdowns, lockdowns, and not, frankly, have to go to healthcare facilities at a time when those facilities are overwhelmed by sick people and, frankly, don't need to be serving people just for maintenance and pickup of their drugs. We're starting to see, and I know we'll hear more about as well, innovative approaches to distance support, whether they're telephone or virtual, whether they're provided by healthcare providers or community providers. Next slide. Elements that, again, have been good ideas for a while, but there really hasn't always been support to take them to scale. And this just gives an example, as in partnership, community networks in Viet Nam, who have worked to support these virtual platforms, expand them right now in real time, to offer support on health-related issues, to marry people who are out of town with resources to continue their treatment, and also to offer that important mental health support. Next slide. And of course, we know that many of the innovations that you'll be talking about, many of the tactics, including multi-month dispensing, but everything that has to do with continuing treatment services, but also prevention and harm reduction services, also depends on these stocks and global supply chains. There are huge efforts through WHO convened work groups, through Global Fund, through PEPFAR, through UNICEF, many of the major procurers of ARVs and other commodities for the HIV response, to really assess production and distribution, supply chains, and what's going to be available. We know that this is going to require constant vigilance and constant problem solving. So far, much of the production still looks good, and we are very much at a global level problem solving when really the shipping, distribution, getting new product out of producing countries and into the countries that need them. There need to be special efforts to make sure a lot of this distribution that used to happen through commercial airlines has an alternative and has alternative permissions, so that you in the front line ideally will have confidence that not just your net stocks are okay, but your clinic level stocks are okay, so that when you give out commodities and use them, they'll also be backfilled so you won't be running out. Next slide. And of course, one of the things we're concerned of is not just ARVs, but also protective equipment, and particularly for healthcare workers. And then I think finally, as will be tapped into today, we are all concerned both about the healthcare services, but also about the social and economic context and inequalities that are being expanded during this time in some ways under. There really is a need for solidarity, for joint political actions, and calling out problems so that responses have the power behind them to help people. Some of these inequalities we see affecting people, affecting population members, the guise of COVID. Sometimes we see this is about places, placings and things where the needs of the people in these places might be more intensive or different than in the general population. And also these places and these people are not always first in line. And then finally, attention globally to emerging issues that we are seeing all too, things that increasing levels of gender-based violence and violence against children, but also some of the human rights abuses that are unnecessary, unproductive, and intolerable. Next slide. And I think one thing we know collectively from the HIV response is how to have rights in an epidemic. We know that a strong public health response is also a rights-based response, that you won't get to the end of an epidemic if people are abused, thrown into hiding, discouraged from being able to engage in the public health response. And I think this publication that UNAIDS put out really taps into the practices from HIV, but also refers to compacts and treaties and global principles that have been put out there time after time, and pulls them into our current context. Importantly, sometimes say, well, it's a balance of rights and restrictions, but we reject restriction. Having rights doesn't mean that there aren't restrictions, but what it means is that restrictions to protect public health are of limited duration, they're proportionate, they're transparent, they're necessary, and they're evidence-based. And as part of these principles, we think it's very important to continue to put out there that a rights-based approach supports and protects healthcare workers, recognizes their increased risk, their dedication, and their mission. Next slide. And so when it comes to bringing our globe together, even in these difficult times, when stress and anxiety are high, we just must call for solidarity. And, you know, we are seeing efforts at solidarity, both in financing and other commitments. Most folks on this phone might know Global Fund has allowed the repurposing of a lot of cash on hand and new monies to support the COVID-19 response. And while this includes direct COVID-19 programming, it also includes the flexibility to sustain current HIV, TB, and malaria services through innovation and supplementation, things that maybe weren't in the original work plan. Our efforts to mobilize new money to suspend debts. Our UN Secretary General has called for appeals for the health response, the humanitarian response, the social and economic impact response. And importantly, I hope everybody here saw that this week, EU gathered partners for an international pledge marathon to really raise both money and commitment to an affordable, equal access to a COVID-19 vaccine, to treatment, and for testing. And in one day, they had $7.4 billion commitments. But importantly, in the commitments and not just a money or a bidding or an influence war. And we are committed as UNAIDS, as part of the global community, to say, you know what? These commodities, these solutions, they need to go to where they're needed most and to who they're needed most by, not by country. And certainly healthcare workers are at the front of the line across our world for making sure we can provide the prevention, the treatment, the testing, and the vaccine when available. We're a proud partner of the Africa CDC PACT initiative, the Partnership to Accelerate COVID-19 Testing in Africa, to make sure lower income countries, in fact, are not at the back of the line, but they're up at the front of the line, and healthcare workers as part of the priority. Next slide. So we really want to say, end where I started, which is a thank you. Thank you for the work you're doing, for the solutions you're creating, for the insights you're sharing, and for the supports, partnership, and dedication you show to saving lives, to working with the community, and working with and for people living with and affected by HIV. Thank you very much.
Thank you very much, Shannon. It is good to know that we count on your leadership, that of Winnie, Viet Nam, and others at UNAIDS who are working with community to ensure the continuity of HIV care. As you noted, there is a need for global and local solidarity against COVID, against HIV, but also against the inequalities that threaten most vulnerable in our societies. And so we're deeply grateful for your spending time with us today. And with that, I'd like to turn the floor over to Dr. Amanda Castell, professor in the Department of Epidemiology at George Washington University in Washington, D.C., also a member of the IAPAC Board of Trustees, to tell us about what we should know about COVID-19, HIV, and antiretrovirals. Amanda?
Good morning. Can you hear me now?
Yes.
Okay, great. Well, good afternoon, and I wanted to thank IAPAC for inviting me to give this talk. And I want to start by thanking all of you who are on the front lines during this pandemic. Whether you're a healthcare worker who's providing care and treatment to people who are infected with COVID, or a researcher helping us to understand the virus and how to curb its spread, or a public health worker doing case investigation and contact training, a policymaker who's helping to ensure that we have the necessary resources to fight this pandemic, and of course our community stakeholders who are ensuring that we do not forget those people most affected by this pandemic. I thank you for all that you're doing. Okay, so over the next 30 minutes, I'm going to give you a brief overview of the evolution and epidemiology of COVID-19, talk about the clinical presentation and diagnostic approaches, talk briefly about antiretrovirals as potential treatments for COVID-19, talk about how COVID-19 infection is presenting among persons with HIV, and then talk a little bit about synergies and lessons learned from the HIV pandemic, and then conclude with conclusions and recommendations. So let's start with the evolution and epidemiology of the COVID-19 pandemic. So it's hard to imagine that approximately 6 months ago, a pneumonia of unknown origin was detected in Wuhan, China. The Chinese government acted relatively quickly with identification of a novel coronavirus within 7 days of detection. And by January, a public health emergency of international concern was declared by the WHO. By February, the virus was identified as COVID-19, and in mid-March, the WHO declared a global pandemic. As of today, there have been more than 3,650,000 cases of COVID-19 reported globally. And so despite the efforts of the Chinese government to contain the virus, we have observed the rapid expansion from Hubei province to the rest of the world. The map on the left shows the WHO situation report from January 23rd, when the virus was mostly concentrated and contained in Asia, compared to the graph or to the map on the right of April 30th, where we see that most countries in the world have reported at least one case of COVID-19. Globally, the impact of COVID-19 has been severe and devastating, with over 3.6 million reported cases and over 250,000 deaths as of yesterday, May 5th. And we've seen that while the virus started in China, the US and European countries, including Spain, Italy, and the United Kingdom, have been most severely affected, and there are only 13 countries in the world that have no reported cases. Unfortunately, we are not new to pandemics. There have been multiple viral epidemics in the last century, most with global spread, resulting in millions of infections and deaths. The Spanish flu pandemic is probably the most similar to the current pandemic, and many of the lessons learned from that pandemic are informing our responses to COVID-19. So at this point, we know that SARS-CoV-2 is a member of the Coronavirus family and cousin to SARS and MERS. Its natural reservoir is believed to be in bats, but we likely observed spillover into humans through wet markets, resulting in subsequent global spread. And the illness that SARS-CoV-2 causes is what we refer to as COVID-19. The response to COVID has relied on several traditional public health approaches, including containment strategies such as contact tracing, isolation, and quarantine. However, as the transmission outpaced our containment efforts, we have focused also on mitigation efforts, including development of medical interventions and application of non-pharmaceutical interventions such as school closures and social distancing. All of this has been implemented with the goal of flattening the curve to minimize infections, slow the spread, and protect healthcare systems from becoming overwhelmed. And while these responses have been used in other pandemics, there have been differing responses by country, which have resulted in variability in case counts and numbers of deaths. For example, in South Korea, the government instituted widespread testing tens of thousands of people per day, which allowed for rapid quarantine and isolation and a likely better estimate of the true prevalence of COVID-19 in the country. In late February, there was an outbreak among a religious group, which was rapidly contained. And since then, the daily case counts have decreased with less than 10 confirmed cases per day. So if we look at Sweden, in contrast to South Korea, for example, the government did not issue any stay-at-home orders, but did prohibit public gatherings of more than 50 people and visits to nursing homes and encourage social distancing in restaurants. They moved to online learning in secondary schools and universities, while primary schools and daycares remained open. And while this has resulted in high numbers of deaths, it also has likely resulted in high levels of herd immunity. Next slide. In Singapore, the response has been very robust. They instituted a circuit breaker approach, which is a package of restrictions. Singapore was hard hit by SARS in 2003, and they were able to reactivate their pandemic preparedness plan. They've conducted enhanced surveillance for pneumonia and influenza-like illnesses, instituted quarantines and contact tracing, and interestingly, are hospitalizing all persons testing positive in a dedicated infectious disease facility. They've also developed extensive public awareness campaigns, and were able to contain the virus until a cluster of cases associated with a migrant worker population was identified, and the number of cases subsequently increased. Next slide. And then the final example is South Africa, which was one of the first countries in sub-Saharan Africa to report a case in early March. By mid-March, the country had declared a national state of emergency, which included no outside visitors, stopping large gatherings, closing borders and schools. And by late March, they had instituted a 21-day lockdown, which was subsequently extended, but resulted in a precipitous drop in cases. The country is now deploying 28,000 community health workers to conduct COVID screening and testing, and a phased reopening was planned to begin at the beginning of this month. Next slide. In the US, the first case of COVID-19 was reported in January 2020. And since then, we have received recommendations for social distancing, institution of stay-at-home orders, and now plans to reopen certain parts of the country. However, despite these measures, the US has been one of the hardest hit countries, with over 1.2 million cases of COVID and over 70,000 deaths. Next slide. So now I want to highlight the clinical presentation and diagnostic approaches to treating COVID-19. We know from data and now from data from China and now from other countries have found that the incubation period ranges from 2 to 4 days with a median of 4 to 5 days. Approximately 1 in 4, 25% of people may be asymptomatic, but among those that do develop symptoms, 80% have mild symptoms that can generally be treated at home. Yet another 20% will experience severe to critical symptoms requiring hospitalization and intubation due to acute respiratory distress syndrome, the cytokine storm, and other complications. The duration of illness is generally 1 to 2 weeks, but can be as long as 6 weeks among those with severe symptoms. And importantly, viral shedding is highest earlier in the illness and can occur 1 to 2 days prior to symptom onset. We've also found from household studies that the attack rate is about 10%. Next slide. Our knowledge of the signs and symptoms of COVID have evolved as we've learned more about the virus. Initially, symptoms were focused on those with fever, cough, and difficulty breathing, but now we know that the constellation of symptoms is vast, ranging from GI symptoms, which we often see in the pediatric population, to milder symptoms such as loss of taste and smell. And knowledge of the symptoms associated with infection is really important, particularly since, at least in the United States, the ability to get tested has focused mostly on symptomatic individuals. Next slide. Next slide. We also know that certain populations are at higher risk of infection and mortality, including individuals 65 and older, residents of long-term care facilities and nursing homes, as well as persons with common underlying conditions such as hypertension, cardiovascular disease, chronic respiratory diseases, among others. The graph on the right highlights the prevalence of those comorbidities and the associated risk of mortality. And you can see that more than 20% of deaths occur among those with chronic renal disease, cardiovascular disease, and diabetes. Next slide. Common laboratory findings when diagnosing COVID-19 include leukopenia, lymphopenia, and elevated liver enzymes and inflammatory markers. Radiologically, chest x-rays will show bilateral multifocal opacities as seen on the image to the right, as well as ground glass opacities on chest CT. And interestingly, imaging may be normal early in infection and yet abnormal in the absence of symptoms. Next slide. Diagnostic testing for COVID-19 has relied primarily on viral RNA detection for acute infection. In the US, early in the pandemic, the Centers for Disease Control and Prevention provided RT-PCR test kits to public health laboratories, which accounted for the vast majority of tests until recently. And again, you can see this in the graph on the left. However, our testing capability has increased with more testing platforms being rolled out, including innovations such as real-time rapid PCRs. We're also starting to see the expansion of serological testing to detect antibodies for IgM and IgG. And the FDA emergency use authorizations have allowed for expanded diagnostic and antibody testing. But despite the advent of new testing technologies, I think that questions remain as to whether antibody detection implies immunity, and it will also be interesting to see how testing evolves. We're certainly starting to see innovations that we saw with HIV testing, including self-testing, rapid testing, and home-based testing. Next slide. So one of the biggest questions that remains is how to treat persons with COVID-19, and is there a role for antiretrovirals? And multiple research groups are working on answering these questions. One example is the WHO Solidarity clinical trial, which is a trial that aims to find effective treatment for COVID-19 while accelerating the clinical trials process. The studies will compare 4 treatment options to standard of care and include multiple countries in the trials. The 4 treatment options being assessed are chloroquine and hydroxychloroquine, lopinavir/ritonavir, interferon beta 1A, and remdesivir. And just due to time, I'm going to highlight preliminary results from 2 of those treatment options, lopinavir/ritonavir and remdesivir. Next slide. So lopinavir/ritonavir is an effective treatment, as we know, for people living with HIV and has been studied among COVID-19 patients as well. The figure on the left shows that compared to controls, patients treated with lopinavir/ritonavir did not have a statistically significant difference in time to clinical improvement compared to those assigned to the standard of care. And in the table to the right, we see that in the same intention to treat population, that treatment with lopinavir/ritonavir did not differ significantly with respect to ICUs, length of stay, duration of ventilation, oxygen support, or mortality. Next slide. And so the study authors concluded that lopinavir/ritonavir treatment did not significantly accelerate clinical improvement, reduce mortality, or viral RNA detectability in patients with serious COVID-19. Next slide. Another drug candidate that's being tested is remdesivir. This was a drug that was originally developed to treat Ebola and works by blocking viral replication and is administered intravenously. When assessed for compassionate use among a cohort of 53 patients, 36 or 58% showed clinical improvement. And I think we've all seen the preliminary results from a recent trial that in which severely ill patients who received remdesivir had a 31% faster time to recovery than those who received placebo. We saw 11 versus 15 days to recovery. There was also a signal that there may be a survival benefit with its use, with a mortality rate of 8% for the group receiving remdesivir versus 11% for the placebo group. And then finally, when comparing a 5 versus 10-day course, there was no difference in clinical improvement, suggesting that a shorter course may work. Next slide. So we know that remdesivir accelerates recovery from advanced COVID-19. However, I do want to note that regardless of these study results, as well as those for lopinavir and ritonavir and other potential agents such as hydroxychloroquine, ongoing randomized placebo-controlled trials will be necessary to adequately assess the efficacy of any of these therapeutic agents. Next slide, please. And next, I want to discuss how we're approaching COVID-19 infection among persons living with HIV. Next slide. So we know from prior pandemics such as SARS and MERS that rates of infection were low and the disease course was relatively mild among persons with HIV. However, we really have limited knowledge of how HIV affects COVID and vice versa. There have been a few case reports from China, Spain, Thailand, and now some forthcoming from the US that show that the incidence of COVID-19 among persons with HIV is low. There's a potential for milder disease with good recovery, and that older age may be a risk factor for infection. However, what we don't know is whether antiretrovirals and other immunosuppressives are actually protective. And of course, we have to remember that many persons with HIV are aging with the disease and may have multiple comorbidities. Next slide. So as our knowledge, and Jonathan, you can click through these. So as our knowledge of the interaction of these two viruses evolves, the WHO, the US Department of Health and Human Services, and the United States Centers for Disease Control and Prevention have issued interim recommendations and guidance, which encourage management of persons with HIV and COVID that's similar to that of the general population, but also emphasizes the need for continuity of care, including having ample supplies of medications, encouraging vaccinations, providing telehealth and telemedicine options, and maintaining social networks while still being able to physically distance. Next slide. Researchers are starting to assess the potential impact of COVID-19 on the HIV care continuum. These are results from a rapid online survey of over 1,000 US men who have sex with men that was conducted by Travis Sanchez and colleagues. The median age of respondents in the survey was 35, 70% were non-Hispanic white, and about 40% resided in the southern US. And of that sample, almost 12% self-reported living with HIV. You can see from this graph that more than a quarter of respondents said that their HIV care visits had decreased. 20% had trouble making or keeping HIV appointments and getting viral load or other lab testing done, while less than 10% reported disruptions in access to ARVs and their ability to remain adherent since the start of the pandemic. Next slide. I think what is most concerning, and Dr. Hayter alluded to it, is that HIV often affects those that are most vulnerable. And we've seen evidence of these health disparities already. This graph is from a paper in Press by Greg Millett and colleagues, which found that COVID-19 cases and deaths increased as the proportion of African Americans increased in US counties. They also found that being uninsured and crowded living conditions were associated with increases in COVID-19 diagnoses among African Americans. And in DC, where I live, we have about 12,300 persons living with HIV in the city. And data from the DC cohort, an observational cohort of persons living with HIV, you can see that most persons are of color. They're facing issues including unstable housing, unemployment, in addition to having multiple comorbidities. And so when we think about HIV and COVID-19 and the historical and long-standing health disparities faced by these racial and ethnic minorities in the US, it's sad but not surprising that we're seeing a disproportionate impact on this population. Next slide. So what can we learn from our almost 4 decades of experience with HIV? Next slide. And you can click through these as well. Many of us in the field are starting to reflect on this, and I've just highlighted a few articles that focus on the synergies between HIV and COVID-19 and how we might learn from our past, as well as address these emerging pandemics. Next slide. So first of all, we know that virologically, there are certainly some shared characteristics of the two viruses, including spillover into the human population, asymptomatic spread, both of which have required risk and non-risk-based testing, high reproductive rates and case fatality rates, as well as millions of people who've been infected and countless others who have been affected by these pandemics. Next slide. I think it's also important to acknowledge that there are shared experiences with respect to how we've responded to these pandemics. These include acknowledging the essential role of testing and diagnostics among those most at risk, the need to implement robust surveillance systems and employ techniques such as contact tracing to curb the spread, the challenges associated with developing effective therapeutics and vaccines, and most importantly, addressing the severe social and economic consequences of these viruses, as well as fighting the fear, stigmatization, and criminalization that is often associated with a new disease. And the figure on the left is from a paper by Xiao et al. And highlights the psychosocial and structural burdens of these pandemics. Next slide. So where do we go from here? There are many challenges and unknowns. For COVID-19, we need to closely monitor the impact of the virus on low and middle income countries, as they are home to millions of persons living with HIV and are often more vulnerable and less prepared to respond to these pandemics. Virologically, we still don't know what the levels of herd immunity are in our populations, nor what levels would be necessary to be able to reopen societies safely and quote unquote return to normal. And we certainly don't have enough data to know if there will be a second wave or if the virus will be seasonal. And of course, there's still a large knowledge gap with respect to treatments and ultimately the development of a COVID-19 vaccine. With respect to HIV and COVID-19, we need to more systematically collect data on cohorts of persons living with HIV to understand the role of age, viral suppression, antiretrovirals, and comorbidities, as well as how the virus affects pregnant women and children living with HIV. And importantly, we need to assess the pandemic's impact on our ability to achieve the 90-90-90 goals. That will include assessing disruptions in ARV access, mental health services, substance use services, as well as STI and HIV prevention access. And certainly determining the role of telehealth and telemental health as we move forward. Next slide. So in conclusion, this is certainly an evolving situation that has had unprecedented global impact and has affected all aspects of life as we know it. We must capitalize on our prior knowledge from other pandemics, and as Dr. Hayter alluded to, our creativity in our response to HIV. How can we determine the role of technology and the sharing of information on a rapid basis, and sharing innovations in care delivery as well that we've learned through HIV and apply those to COVID-19. From a prevention standpoint, we have to protect the most vulnerable, including persons of color and those living with HIV. Scientifically, there's a wealth of research to be conducted on COVID-19 prevention, treatment, and vaccine development, and we must balance the urgency of this work with sound scientific approaches. This again will include conducting randomized clinical trials to adequately assess potential therapeutics and future vaccine candidates, and designing systematic studies to assess risks for COVID and monitor outcomes among people with HIV. We must also work collectively to advocate for structural and policy level changes to address the racial disparities, stigma, and discrimination that often emerge in these pandemic situations. And finally, we have got to take the lessons learned from HIV and now that we're learning with COVID and begin to plan for the next pandemic so that we are adequately prepared when it arrives. Next slide. So I want to acknowledge several of my colleagues at GW, as well as Steph Barral, Greg Millett, and the IAPAC team, who provided their input and assistance with preparing this presentation. And with that, I say thank you.
Thank you very much, Amanda. And following that excellent presentation, I'm going to invite Dr. Bob Remian, Professor of Clinical Psychology at Columbia University and the co-chair of the Adherence 2020 conference, to speak to us about managing mental health conditions in a COVID-19 context. Bob?
Okay, can you hear me now? Jose, Jonathan?
Yes.
Yes, we can.
Okay, good. And hopefully you're seeing my slides now?
Yes, we do.
Okay, great. Well, thank you. Thank you to the organizers. Thank you to everyone who's here. As others have said, I want to also give a special thank you to all of you. I imagine there are a lot of providers on the line, all of you working on the front line and support staff or frontline workers. Thank you for all that you're doing. I regret not seeing you all in person. And thank you to Shannon Hayter and Amanda Castell for doing a nice setup. Amanda, hi. Sorry, I'm not seeing you in person. Particularly your closing comments were a great setup for what I want to accomplish in my talk. So here's an outline of what I'm going to talk about: the psychological challenges in the HIV and COVID pandemics, similarities and some differences. I'm going to be focused throughout on the mental health challenges associated with COVID, strategies for coping with the pandemic, impact on healthcare system, and also to try and be optimistic and some hope for the future for changes and innovations that I think are much needed. So throughout my talk, I'll be trying to look at and weave the intersection of HIV, COVID-19, and mental health. Both the associations, their influences to each other, and also lessons learned. It's reassuring on a certain level that there's attention being drawn to the needs for psychological and mental health interventions, that psychological trauma is probably the next crisis for not just health workers, for the general population, for all of us, for our patients, and for ourselves. And this is being recognized by local jurisdictions and national organizations, et cetera, et cetera. So that's reassuring. I always like to draw comparisons to the early days of the HIV epidemic and what we're experiencing now with the coronavirus epidemic. Early days of HIV, and like now, we're confronted with lack of effective therapy, people going after experimental treatments, clearly a lot of fear of contagion, a lot of isolation, which happened early days of HIV and is happening now, of course, with COVID. And it's not clear to what degree shame, secrecy, and discrimination, which was so paramount in the HIV epidemic and unfortunately still is, a great deal of stigma. It's not clear what role that will play in the COVID epidemic. I think Amanda made reference to things like criminalization. We still see that in HIV. We've certainly seen it in the past. We still see it in some jurisdictions. We don't know how that will play out with COVID as we move forward. Also looking at the striking similarities of there being multiple loss and grief. In early days of AIDS, and now we're seeing overwhelmed hospitals, overwhelmed morgues, funeral homes, cemeteries, people not being able to attend their funerals or hold funerals or even be able to attend burials for their family members. And with both epidemics, there are associated economic hardships and, of course, and my focus on mental health and well-being, a lot of emotional toll across both of these epidemics. Also, other early day commonalities. If we think back to the early days of HIV and think about now, there's a lot of confusing and conflicting messaging about how to behave, contributing to a lot of fear, anxiety, and insecurity. We see in some places, and I can speak for the US, but I think in other places, some other places as well, there's a lack of poorly coordinated governmental response. And we're seeing already a growing dependency on community organization, on activism and volunteerism. I know a lot of my HIV activist colleagues are at work and particularly being mindful of the HIV population, as Amanda referred to, and their needs. And so some of those same people are playing a role. The misinformation and unfortunate politicization of the issues are contributing to general frustration, anger, and more fear. A lot of us are reassured, particularly in the US, to see Dr. Anthony Fauci, who was a leader in the early days of the AIDS epidemic, to see him in the leadership role here now with COVID. The other striking commonality, of course, has already been made reference to. I think it deserves repeating, that we see a concentrated burden in vulnerable communities, and this is particularly racial and ethnic minorities and immigrants, those with reduced financial means, which means food insecurity, housing insecurity, etc., and there may be work insecurity as well, and people losing their jobs, as well as those with lack of adequate or optimal healthcare access. In the COVID epidemic, we're seeing that essential workers who are out there working on the front lines, and that's not just hospitals, but that's also grocery stores and delivery people and firemen, policemen, transportation workers, etc. They're not able to shelter in place. And these folks are often, unfortunately, synonymous with some of the above demographics, with having less financial means, and being of racial ethnic minority status, or at times being immigrants. I think it's important to note that for people living with HIV, there's a vulnerability for re-traumatization, and we're seeing that in our clinical work, and some people are starting to write about that and publish about that, and what that feels like for people having made it through the HIV epidemic and experiencing re-traumatization with what's going on now. And of course, there's always a question with those with mental health conditions may also have increased vulnerability to coronavirus acquisition. We don't know that yet, but when we talk about lessons learned, we know that mental illness is a risk factor for HIV acquisition. We know that it contributes to 4 to 10 times the increased risk for acquiring HIV. And that in particular, mood disorders with alcohol, substance use, and other conditions contribute to even a higher risk. How will this play out in the COVID epidemic? Another example of seeing when we have increasing co-occurring conditions like depression, alcohol use, stimulant use, polydrug use, childhood sexual abuse, the probability of staying HIV negative goes down as these conditions increase. How will this play out for populations with coronavirus? We know that rates of selected psychiatric disorders are high compared to the general population among people living with HIV. And again, you see the most common disorders of substance use, including alcohol, depression, PTSD, etc. Just to highlight here the numbers again, these are the most common mental health related problems that are high among people living with HIV. And you can see these very wide ranges going up to a very high prevalence, up to 67%, for instance, in depression. And then for both current and lifetime alcohol and substance use disorders, anxiety, PTSD, HIV-related symptoms of cognitive disorders. We see that in HIV, where it's starting to see some of that happening with coronavirus. And then issues like pain and insomnia. And I guess the point is, these are also some of the same mental health problems that are now emerging during this COVID pandemic. So the psychiatric vulnerabilities that we're seeing in this current epidemic, increased rates of depression, anxiety, substance use, and PTSD disorders have been found to follow natural disasters such as earthquakes, hurricanes, tsunamis, or floods. So we should expect to see that. And some of these, such like an earthquake, I mean, there's always an aftermath, but some of these things they happen and then they're done and there's the aftermath. We're dealing with a chronic pandemic right now. So I think we're certain to be seeing these kinds of mental health challenges. I think we know that people with pre-existing vulnerability to psychiatric disorders, including anxiety, depression, obsessional symptoms, substance use, suicidal behavior, and impulse control disorders, are likely to be especially vulnerable to stress-related symptoms with this pandemic. And looking forward, I think we have to realize that long after the physical threat of infection has subsided, if and when that does subside for us, the psychological sequelae in vulnerable people and behavioral effects of persistent distress will likely be ongoing. Again, to highlight some of the main psychological challenges in the COVID pandemic, there's physical and social isolation that our patients, our health workers, ourselves, basically the general population is all experiencing. There's loneliness associated with that. There's a lot of dealing with and coping with loss. So it's not only loss of people who are dying in our families, our colleagues in our community, but also other personal losses, personal loss of our sense of normalcy, of being able to engage in our normal routines, of being able to socialize the ways that we're accustomed to, for people to be able to work, the loss of work, loss of income. So, I mean, loss is just was true in the HIV epidemic, and it's so true in cutting across the COVID epidemic. Of course, the challenges of anxiety, particularly associated with a lot of uncertainty. We are seeing already increased use of alcohol, tobacco, and other drugs as not the best and most adaptive coping mechanisms. A lot of reports of difficulty sleeping and concentrating. I already mentioned job loss leading to lower self-esteem and well-being in general, fears and concerns for family members. And I would posit that this is especially difficult for populations with pre-existing mental health conditions. They're already vulnerable at the outset. Other signs of distress that we're seeing during this pandemic: feelings of numbness, disbelief, anxiety, fear. A lot of reports of changes in appetite, energy, activity levels. People can't be active in the same way they are, but they're also not even feeling energetic. A lot of difficulty in concentrating, difficulty sleeping. There's a lot of reports of nightmares, vivid dreams, upsetting thoughts and images. Physical reactions that are associated with this, such as headaches, body pain, stomach problems, skin rashes. We're seeing worsening of chronic health problems. And as Amanda mentioned, that people are probably getting less routine care for their other chronic health problems, and that's going to be a growing problem. A lot of reports of anger, short temper, unfortunately, rises in reports of domestic violence are happening now. And I already mentioned increased use of alcohol, tobacco, and other drugs. Also, this is new, and I'm not going to get very much into this because this is just really emerging, but we are seeing, and we're seeing reports of neurological sequelae with COVID illness. So as Amanda Castell pointed out, that how the virus is manifesting in different ways, not just respiratory across individuals. Well, there's now reports of over 1/3 of patients developing neurological symptoms. And you see the list here, including strokes and seizures. But I also want to point to the potential psychiatric or psychological sequelae. So there's reports of delusions and hallucinations. We know that the virus crosses the blood-brain barrier, thus can have neuropsychiatric consequences. There's inflammation in the brain and the central nervous system. So I believe we'll see more emerging data of other psychological and psychiatric sequelae that are associated with the virus itself. I think we, of course, have to point out, and probably this means many of you who are actually listening right now, the unique challenges for healthcare providers. The scale of this pandemic is overwhelming. What were standard plans and responsibilities and training that people went through in their medical school, it's being altered. They're having to work outside of their areas of expertise in a crisis management way. Many are thrust into these situations where they're caring for overwhelming number of patients. And this is in the backdrop or the context of there being no specific effective treatment as of yet. We just heard a report about some things that's showing some efficacy, but we really don't have the full treatment, evidence-based treatment that is needed. And that's very stressful for providers. Providers having to provide intubation services to patients in the hospital and not having the proper protective equipment, and the protocols are inadequate. Again, highly stressful situations. A lot of our providers are helping very high numbers of patients who are, and primary care providers are not typically accustomed to managing anxiety, and with dying patients, you know, a typical provider would probably maybe make a phone call to a family and say, this might be the time to come in and visit with your family member because it looks like, you know, they're terminal now. Well, the providers themselves are having to be the people who are there connecting their families. For the last time, sometimes they're holding up iPads or cell phones to have the patient communicate with their families as they're dying. And it's the providers that are there with them and administrating these kinds of services. So this work is highly intensive and involves nonstop critical care. And this can also, unfortunately for providers, include physical isolation from their family. We have lots of reports of healthcare providers not wanting to, out of fear of infecting their family, not going home, not living with their families. I know of people who have been sleeping in their cars or renting hotel rooms or small apartments or places where they can stay, or staying over in the hospital. So there's isolation from family that's happening. Bottom line message to providers is, and we're all human, regardless of how healthy or well-adjusted you may be, the experience of stress, anxiety, frustration, and other emotions are likely to emerge. Here's a nice picture, I think, tips for just everyone around coping. I think one of the basis of coping and figuring out how to cope with challenging situations is to first really take a look at what's within my control and what's not within my control. We can't control what other people do. If other people follow the rules of social distancing, we can't control their actions. We can't predict what's going to happen. We're living with uncertainty. We can't change other people's motivations. We don't know how long this will last. We can't control how other people's react. And yes, we can't control the amount of toilet paper that's available at the store. But when coping, we think about focusing on the things we can control. Our own attitudes, trying to look for positive attitudes. We can ourselves follow recommendations and guidelines from places like the Centers for Disease Control. We can control our own social distancing. It's important to turn off the news every now and then, and limiting our social media, finding fun things to do at home, particularly with family members and those people who have children, and of course things like mindfulness and kindness and grace. This slide you're seeing right now, I could probably do a half-hour talk on just this. The point I'd like to make that as we move forward, the importance of resilience. Resilience does not mean going back to the way things were. It means being able to move forward and cope with change. So it includes these categories of, to be resilient, we have to engage in self-care. I'm going to talk a little bit more about that in a minute, but getting our own basic needs met. So these messages, by the way, that I'm giving, if it's not clear, this is to you who are listening, but these are things to communicate to your patients, to your colleagues, to your family members, that this is just true for all of us. Being focused on our values and living our values. Maintaining connectedness as much as we can. Seeking support from other people in our lives. And if you can't do this physically, we know people are doing this virtually, and it's very important. Self-reflection on what's happening and what this means for reevaluating our values and how we want to live our lives and what is the purpose of our lives, etc. Having hope and looking towards and being hopeful for things to be able to, there being positive changes that might come out of this. Cultivating gratitude, practicing mindfulness, being flexible, and also forgiving. We have to be flexible, as I just said before. There are things in this that we cannot change, so we can focus on the things that we can do. Being forgiving to others, but also to self. A lot of us are not functioning at our best level. People are not getting everything accomplished they might want to get accomplished. And we have to have forgiveness for ourselves that we're all dealing with a very, very challenging life and situation right now. So this is all about resilience. These are all evidence-based strategies that actually show benefits of just doing these very concrete, basic, straightforward things in terms of taking care of oneself, that whatever that means for you, and different things work better for different people. Meditation, prayer, relaxation exercises, deep, slow breathing. There's a lot of evidence that this does have a beneficial impact on our central nervous system, on our well-being, and on our physical symptoms. This is how people often get rid of headaches or the stress that they're experiencing. Things like yoga, mindfulness, stretching, all of these things can do in one's home, and again, advising patients, advising colleagues, and doing this for yourselves. Hydration and healthy eating, exercise when you can, especially if one can go outdoors, that is useful. Rest and sleep are really, really important. Being mindful of avoiding excessive alcohol or other substances intake, reaching out to others, both for your own personal support and support of others, the mutual give and take and support that happens when you communicate with people in your lives. People are always reminded to not make decisions that can result in major life changes when going through crisis situations. It's important that we ask for help when we need it, and that we delegate things to other people, not try and do it all on our own. And as I already mentioned, there's actual evidence that it is beneficial for people to turn off the news, at least now and then, limit how much and who you watch. A few tips, particularly for people working from home, and this is for a lot of people right now. We're not having this built-in separation between work and home life, so we have to pay attention to that. A lot of experts are saying it's important to try and keep some steady routines. You know, even if you don't have to, you know, take a shower and change your clothes or make your bed. Things that even if they may not be necessary to do, they might be helpful for your sense of well-being. There's the providing telehealth and work from home. This may increase feelings of isolation and stress. People need to take time to check out their work and home, settle in, and try and find a way where you say, okay, I'm putting work away now, and now I'm moving into my home life. Some people find that challenging, but there are ways of doing that. You might have a place in your home where you do your work and then you go to another place to be with your family. And I think setting work hours and leaving time for breaks is important. Some people are struggling with that, and very important, again, to set schedules for time with your family and friends. Now, of course, I'm talking a lot about the stress that are being experienced by a lot of people, but of course, we always have to distinguish between mental distress and mental disorders, particularly during a crisis like this. So mental distress can occur in response to any adversity, as we've been talking about. And so this may be more severe for others, like those in the front line, but everyone is experiencing some, I think it's fair to say that just about everyone's experiencing some level of distress. And this doesn't necessarily meet criteria for a psychiatric diagnosis or anything requiring specialized mental health interventions. These things respond to the kinds of things I already mentioned and to other supportive strategies. And I guess part of the message I'm giving to you all as providers is, with your patients, even if you're not a mental health care provider, the kinds of things I've been recommending are things you can share and communicate with your patients, where they don't necessarily need a referral to a licensed mental health care provider. However, people there are triggerings of mental disorders. As I said earlier, people who already have pre-existing mental conditions, they're vulnerable during times of crisis. And here's where there is a need for referral and connection to care. And I'm going to talk a little bit about the challenges of some of the disruptions in care that we're seeing and what that means for mental health care. I just want to remind us all of the backdrop and the reality that we have an unfortunate mental health treatment gap across the globe. 67 people with behavioral health disorders not getting behavioral health treatment, 30 to 50% of referrals, 50% of referrals from primary care to outpatient behavioral health. Patients do not make that first appointment. And 2/3 of primary care physicians report not being able to access outpatient behavioral health for their patients. And there's a lot of things that structural issues behind this and policies, as well as things like stigma and stigma of mental health. Mental health disorders. So as we just heard in the last presentation, there's disruptions in routine healthcare due to this pandemic. We're seeing in HIV care where people are not going as regularly for their routine viral load checks, which also means checking on their well-being, their adherence, etc. I think, unfortunately, these disruptions are going to further strain the mental health and primary care systems, exposing the limitations in our infrastructure, workforce, and accessibility. So what needs to be done as we move forward? Again, from a mental health perspective, we have to think about increasing the increased risk of adverse mental health outcomes for people with pre-existing mental disorders, people who reside in high COVID prevalence areas, people who live with someone affected by this virus, people who have a family member or close friend who has died, people who are socially isolated, have little available emotional support. We really have to pay attention to those who are isolated. So here's where we have to focus. I'm proposing focusing our efforts, the populations, for healthcare professionals themselves, as best as we can, mitigate adverse mental health effects that's happening there. Providing adequate personal equipment, of course, is important for that. Access to COVID testing, education concerning the disease, training and management of COVID, providing emotional and physical support, developing more flexible work schedules for our healthcare providers, and a commitment to support and care for workers who become ill. I know it's happening across the region. I'm part of a task force at Columbia University Medical Center, where those of us who can work virtually, there's a task force providing a lot of online and virtual support for hospital workers and staff. We need increased primary care mental health surveillance, and so this means routine screening for depression, anxiety, substance use, and I always advocate for these things being integrated in all of primary care. I think in the HIV field, there's been a recognition for some time of the importance of integrating mental health care with primary care. I think it's true of all primary care, not just HIV care. So we have to do that and ultimately be able to provide evidence-based services and treatments for the complicated grief that's going to be people are experiencing, for adjustment disorders, and for depression. I think the field of psychiatry, psychology is particularly suited to use of virtual methods of providing mental health services. I'm glad that our next presenter is going to be talking a lot about telemedicine. I think this is an opportunity. While telemedicine technology has existed for a while, for almost 3 decades, it's taken the impetus of this crisis to overcome the inertia for practitioners to actually use it. So this presents new challenges to delivery of care, including mental health care, but I would say it presents opportunities. I think that through telehealth, there are ways of actually integrating mental health care into primary care in ways that we haven't done so well in the past. The need to develop support groups, peer counseling services, crisis helplines, expanding services, enhancing accessibility through the use of telemedicine, and formalizing linkages between primary care and specialty mental health services. This may help address some of the emerging mental health needs that are so paramount in this pandemic right now. I think careful planning, integration of these basic mental health services into outpatient primary care will be critical to minimize the adverse mental health effects as we move forward with this pandemic, because this is going to be with us for a while, and I think that's very clear to us now. As I start to wrap up, I kind of like to look for the optimism. I've pointed to how, even though the brain and body form an integrating system, unfortunately, the care for them has been siloed, right? Mental health care has been across the board inadequate in most of our healthcare settings and not well integrated. The recognition that the psychological trauma and the psychological distress associated with this pandemic is with us. It's going to be with us for a long time. We're going to have to be paying attention to this going forward. So the optimist side of me is suggesting that the challenges we've had with coordination or co-location or integration of mental health care into primary care, I think telehealth can overcome some of these obstacles, even just a very straightforward way of less worry about physical location of services. Some people they see a primary care person in a hospital, and if they're referred to mental health care, it may be either in a different floor, in a different building, or even in a different part of town. Through telemedicine, I think with innovation and creativity, we can do a better job and look forward to actually advancing this integration and having these systems talk to each other so they're not siloed. So again, I like ending on an optimistic note that coming out of this, there may be innovations and changes in how we deliver mental health care that I think will be beneficial for everyone. And particularly, of course, including all of our populations living with and affected by HIV. So I'd like to thank, in particular, I want to shout out and thank Christopher Ferraris, who really helped put this together with me and is really a co-author on this presentation, and my other colleagues at Columbia and the New York State Psychiatric Institute who contributed slides into the thinking of this presentation. I thank you very much for your attention, and I will end there. Thank you.
Thank you very much, Bob. Very important reminder of our humanity. Of course, the need to be in solidarity, but to take good care of our needs, including mental health, amongst not just patients, but also health workers who are at the front lines. It's a good segue to our next speaker, Dr. Varesh Patel from the Albert Einstein College of Medicine will speak to us about implementing telemedicine in a COVID-19 environment from the epicenter of the COVID-19 epidemic in the United States, New York City. Dr. Patel.
Okay, can you guys hear me okay? I think you can. Anyways, thank you for this invitation. And what I'd like to do today is just give you a brief background of, COVID in New York City. Many of you may have been seeing the data, but, New York City truly is the epicenter, I think, right now of the COVID pandemic for multiple reasons. And where I practice and where I work at Montefiore Health System in the Bronx, we're probably the hardest hit borough, and so I'll go into some of that. And then what I'd like to do is just talk about our experiences implementing telemedicine in this crazy sort of time that we've never seen the like of, and talk about some of the challenges and what we've done to overcome some of those challenges, but what do we continue to face and what the future may hold, and sort of what what implications does that have for both practice as well as for research. Okay, I have nothing to declare, so I'll just keep going forward. So so this graph just gives you an idea of the total number of cases of COVID globally. So the blue line on the top is total number of COVID cases, and it's somewhere around 3 million, 3.6 million. The US cases in red is about 1.2 million, so about 1/3 of the global cases. In New York City, what we see is we have over 176,000 cases in New York City alone, which accounts for majority. And then these other lines are COVID cases in other high prevalent counties within the state of New York. But New York City is probably the hardest hit in the US, with just an insane amount of cases of COVID. And so what does that mean so there's a lot of cases, but what does that mean for our healthcare systems and institutions? So this graph from the New York City Department of Health and Mental Hygiene shows, the x-axis is the date, and the left axis is the total number of hospitalizations on a daily basis. So this graph, so what we see is, starting in early March, where we had basically no hospitalizations due to COVID, it quickly ramped up over a 2 to 3 week period where we were having over 1,500 cases of COVID, patients with COVID being admitted on a daily basis to all area hospitals. And this had a tremendous, and this still has a tremendous impact on our healthcare infrastructure. So hospitals in New York were not empty before COVID, as in most places. We were quite full, and in the areas which take care of more marginalized populations, those hospitals were largely full and operating at capacity already. And so if you can imagine what this does is when you have a huge influx of this many patients in such a rapid period, what has to happen, all the things that has to go into place. So this is really about logistics, people thinking on their feet, mobilizing resources, and just tremendous efforts it's taken, and it continues to take, to deliver the best care we can under these circumstances. So in New York, so again, the top graph shows the total number of daily cases being reported in New York, in the city, and then the bottom graph shows the total number of people dying due to COVID. And so look, thankfully we're on a downward trend, although we are nowhere out of the clear. What it looks like is at the peak we were averaging about 800 deaths a day due to COVID. And now to put this in perspective, when we look at, so this graph shows number of deaths due to a couple different causes. So the first bar graph is the total number of deaths during the Viet Nam War among New York State residents, which was 4,119. And this was over, several years. This was not over a 3-week period or a 6-week period where we are now. In 9/11, this was a single day attack, but it was close to 3,000 individuals who ultimately died, as a result of the 9/11 terrorist attacks in New York City. And what we see on the far left bar graph is the total number of deaths due to COVID-19 in New York City as of yesterday from the New York City Department of Health data. So it's almost at 18,000. And, these numbers continue to climb because as we see on the bottom left corner graph is we still have about 200 to 300 deaths per day continuing. And, the rate is slowing down, but it's not, but it's probably going to be a slow trickle. So we don't know what the total number of deaths is going to be, but it's high, any way we cut it. And, thinking about who is most affected and who is not most affected, we really need to examine racial and ethnic disparities in COVID. And so this graph, created by the New York City Department of Health, shows you 4 groups of, or 4 populations in the city. So people who identify as Black, African American, those identifying as Latino, white, or Asian. So on the far left in the blue is the total, is the case rate. So this is per 100,000, this is age-adjusted numbers per 100,000 population. And the blue graph shows the case rate per for total cases of COVID. So for Black African Americans is 659 individuals being diagnosed with COVID, compared to 494 for white individuals, and a little bit fewer for Asians at 231. So that's total number of cases. But now when we look at the hospitalization rate, the middle sets of graphs, so 379 for Black or African Americans, almost 300 for Latinos, and those numbers are about 1.5 to 3 times the amount for white individuals in New York City. When we look at deaths due to COVID-19, for Black and Latino populations in New York City, the rate is twice as much as white individuals. So this is, these data, as Dr. Castell pointed out in her slides earlier, is extremely alarming, and we really need to, not only think, but we really need to act proactively in addressing these disparities. And I think many of us are not shocked by these disparities for several different reasons, but these are disparities we see with multiple health conditions, including HIV in the US and in New York City. So to give you a better sense of, what may be going on, so New York City is made up of 5 boroughs: Manhattan, the Bronx, Queens, Brooklyn, and Staten Island. And, this is what New York City was, just a few weeks ago in early March. This is Times Square on the left, and then different images of, and we have a very high population density, people everywhere. And, overnight, the streets were empty. Times Square was shut down probably for the first time in, we don't know when. There's hardly anyone on the streets. This was early March. The city, and this is probably true for most places in the world, which went on severe lockdown or shelter in place, where it became a totally different way of life that none of us are used to living. And one of the things in New York City, perhaps similar to other places in the world, is, people live in small living quarters. There's crowded households, crowded housing, or just small spaces. And so people are not used to being indoors in such small spaces all the time. And so, this has a lot of implications for not only COVID, but also thinking, as Dr. Remian pointed out, about mental health issues and, how do we deal with such tremendous changes in such a short amount of time. Just more scenes from the city where we've had a lot of individuals, lining up to be able to access food and other essential services. And one of the things that happened, because our hospital systems were being overwhelmed, this is a picture from the Javits Convention Center, which is a really large convention center in Manhattan. And the US military was brought in to build a makeshift Army-style hospital, and that's what they did. And so all of these sort of partitions you see are patient rooms, and then the image in the top right is an example, is a picture of what a patient room, a temporary patient room looks like. And this was built within a span of about a week or so inside the convention center to accommodate the huge influx of patients who are getting hospitalized due to COVID. thinking about COVID disparities, and how that relates to implementing telemedicine and where I practice in the Bronx, is looking at the rates by boroughs. So the Bronx has the highest rate, or experiences the highest rate of cases per 100,000 individuals, and Manhattan has the lowest number of cases. So in the Bronx, it's almost 2.5 times the rate of Manhattan. And to sort of drive, and to paint a picture of why, is really thinking about, where do people live and other factors. So in these 3 maps of New York City and New York City neighborhoods, what we see is the far left picture is the Latino population. And so the Bronx, located in the northern part of the picture, or the top part of the picture, in the dark, where we see the most dark blue, we have a very large concentration of Latino individuals living in the Bronx. And then same thing with African Americans. We see high pockets in Brooklyn, some in Queens, and then again, Upper Manhattan and the Bronx. When we look at people who did not complete high school, some of the highest rates of non-completion of high school are in the Bronx. And so the dark blue is 26 to 41%. So we see that majority, or almost all, of the Bronx neighborhoods, over 26 to 41% of individuals have been unable to complete high school, relative to the other boroughs. In these next series of graphs, the middle graphs, so the far left again is people who did not complete high school. The middle graph talks about poverty, or displays poverty. So the top of this picture, in the middle image, 26 to 34%. The dark blue represents 26 to 34% of individuals living in poverty, and so that's the Bronx. So the Bronx is the poorest borough in New York City. It has some of the poorest congressional districts in the US. And when we look at HIV rates, again, we're not surprised, but this was in 2000. This is data from 2016, but it looks the same, currently, where the highest rates of new diagnosis were largely occurring in the Bronx, which maps onto poverty, low rates of education, sort of other social determinants and structural factors, as well as racial and ethnic disparities. And so what does that look like for COVID? So we see almost exactly the same image in regards to COVID. So we see the highest rates. So again, at the top of the picture here, or the top of the map here, the Bronx has the highest rates of COVID cases in the city. And this is just cases, but when we look at death rates and hospitalization rates, these rates are, I think the disparities are even more stark. And here's a series of graphs. So the middle graph looks at hospitalizations by borough. So what we see is, in the Bronx, we have almost twice, or about 1.5 times the hospitalization rate as Manhattan. And Manhattan is the wealthiest borough, has the highest levels of education, and has the lowest minority population of any of the boroughs. When we look at the death rates in the Bronx are, close to 2 times the rate of Manhattan. So we continue seeing large disparities. And so to also think about disparities not only by populations, but also by systems and institutions. So what does that mean for healthcare institutions that are already providing care for some of the most marginalized populations and vulnerable populations? And this has had a tremendous impact. So at, so Montefiore Health System, where I work, is the largest healthcare provider in the Bronx. It's comprised of 4 acute care hospitals in the Bronx and a large network, almost 15 primary care health centers located around the Bronx. It's among the largest, has among the largest patient populations with HIV. Close to 3,000 individuals are being cared for in our institutions, or over 3,000. And, you know, they receive care in a couple of different venues. So one large venue where I work is through the primary care health centers. You know, another venue is through the infectious diseases clinic, and then a adolescent medicine specialty care clinic. We care for high levels of uninsured patients, patients with Medicaid or who are low income. And, you know, on a daily basis, we all encounter tremendous social and structural barriers to care for our patients, or, you know, what our patients are facing, which, you know, pose challenges that may not pose challenges in other systems in the US for providing such care. And so we're already dealing with this on a daily basis, and, you know, and actually providing really high quality of care to our patients. But now with the COVID pandemic hitting, you know, what does that mean? So at Montefiore, when we look at, these are total number of hospitalized patients within our institution on a daily basis. So from early March, we had very few cases, and we go to middle of, you know, we peaked somewhere in early April, and we had somewhere around 1,800, 1,900 patients admitted to our hospital. And so, you know, within our system, we have close to 1,500 beds, or, you know, give or take, depending on how you count it. But these beds were largely full. Our hospitals were full before COVID hit. And so we've had to double the capacity of our hospital systems. And, you know, and not only bed capacity, but also thinking of the healthcare workforce and providers. So where do we, you know, overnight essentially get providers who know the system, who are able to provide care and do so in an overnight system? And that's largely been by mobilizing staff from all corners of the hospital, but also from all corners of the outpatient enterprise, from all of our ambulatory sites, primary healthcare sites. So we've had providers who've never, you know, who may not have practiced inpatient medicine being assigned to inpatient care, you know, working alongside people who are experienced and being mentored quickly, but sort of a apprenticeship model. But we've had nurses, social workers, you know, patient care representatives, front desk staff, just administrative staff, all being pulled from the outpatient clinics to support this tremendous influx of patients who are hospitalized and needing care. You know, and that's also had large implications for providing outpatient care, including HIV care, because there aren't providers now available in the outpatient setting during this during this epidemic. So, you know, here's an example of what happened within our system. So on the left, this is one of our conference centers within the hospital where, you know, it's a large conference room. And, you know, within a span of a week or so, it was converted, like we saw earlier with the Javits Center, into a makeshift hospital ward where we had patients with COVID being hospitalized. And, you know, and we, you know, the hospital was shut down to visitors. You know, every corner of the hospital that wasn't usually used for patient care was turned into patient care areas. We had to mobilize just tremendous amounts of resources because, you know, doubling our capacity also meant acquiring hospital beds, acquiring materials, acquiring all the equipment we need, you know, and just everything we need to be able to provide care to all of these individuals. So shifting to HIV and HIV telemedicine, just to give you an idea of, you know, so I talked about how HIV care is delivered within our system or institution. You know, in the primary care network, we currently, HIV care is delivered through about 10 community health centers. And in these 10 community health centers, we provide care to over 1,000 patients living with HIV. In these health centers, we also do a lot of sexual and gender minority health care, as well as PrEP, in addition to routine primary care and all of what that encompasses. Our HIV care is, a team-based approach, which is provided by physicians, nurse practitioners, physician assistants, social work, HIV-specific social workers, psychologists, and a psychiatrist, a clinical pharmacist, navigators, and counselors. And so a lot of the work the social workers, the pharmacists, the navigators were doing was already virtual. So we have a small team of individuals supporting these 1,000 patients, but they were not necessarily interacting with them face-to-face all the time, but they were regularly. The navigators, especially, for patients who are newly diagnosed or needed that extra support, would accompany patients to visits, would help navigate them through getting their medications, insurance forms, just all of the tremendous barriers that we have in the US to being able to provide care and access care that doesn't exist in many other parts of the world. So when we look at, this graph is about the total number of outpatient clinical visits occurring at Montefiore in the primary care health centers. And so it's not just HIV, but all patients. And so what we see is, we had over 2,000 visits per day. These were face-to-face visits, occurring in our primary care health centers. And, essentially over a 1-week period in mid-March, we went from over 2,000 to just about 100 visits per day. And, it's a couple of things happened. So we shut down the clinics due to to COVID and not wanting to transmit COVID from patient to patient and providers to patient and patient to providers. And second is all of these providers were being pulled into inpatient care, so they weren't even available and staff weren't available at the centers. And so the few face-to-face visits that were occurring were for urgent, really urgent care, vaccinations for children, for newborns, and for essential or urgent prenatal care visits. And those were about it. And so when we think about telemedicine, there's been talk about telemedicine for quite some time. And so as Dr. Ramian mentioned, there's been a lot of work put into place for using telemedicine in the US for quite some time, but it's never really taken a hold until this pandemic. And so this cartoon shows, some of the first telemedicine sort of ideas were about using radios and radio communication to try to have a telemedicine or a virtual visit with a provider. And that's, and that's what we've sort of are coming back to now, is trying to figure out how do we deliver virtual care when, one, providers are not used to doing this. We don't really have protocols in place to provide care, and just a whole host of other issues. So in response to this, New York State Medicaid, similar to many other Medicaid or insurance programs in the country. So Medicaid, for those outside of the US, is the health insurance program that provides care for or coverage for low-income individuals. Each state has its own policies as to who qualifies, who doesn't qualify. And through this system, people are able to receive care if they're low income. And so Medicaid put out emergency guidance as to how televisits or telehealth visits could occur, and lifted a lot of regulations that were in place before then. And so that included things like, where providers had to be. So previously, providers had to be at their usual, for New York State and in Medicaid, providers had to be at their usual place of care, meaning in their clinics, but a patient could be anywhere. So in this emergency guidance, providers could essentially deliver care from their homes, and to assist in social distancing, and also to acknowledge facilities were closed, but patients needed access. Montefiore similarly, on the same date, put out some emergency guidance around how to start providing telemedicine visits, and quickly worked with an existing vendor to adapt a platform that we could use to start doing video visits. Although I'll show you, the video visits haven't truly taken off, but we were restricting we were really limited to using telephones during this first phase. So our current telemedicine visits, so what happened? So all appointments that were currently scheduled or were being requested were all being converted to telemedicine visits, meaning that patients could not come into the clinics, but were being informed by the secretaries or the receptionists or our patient service representatives and being called that that their doctor or provider would call them on that day around the time their appointment was scheduled for. And however, as you can, we take care of a lot of low-income individuals, and there's a lot of barriers to doing that. So people don't have working phone numbers. Phone numbers are disconnected. Unlike many other countries, incoming phone call, mobile phone calls and incoming SMS messages are not free. And so we still had patients who were showing up to our clinic doors, so we needed staff at the entrances, instructing patients to basically not enter the clinics, and that they would be called, but many of our patients were not, didn't have phones, and so we had to quickly create protocols as to how to do that, again, with bare bones and limited staff. There was changes, the other thing that was going on is providers were being rotated into the inpatient setting on a weekly or every 2-week basis to help with the COVID, and deployed into the inpatient setting to help with COVID. And so as individuals were coming out and coming back into quote unquote outpatient care, people were constantly having to learn what the new protocols were, and the people who were just learning it or getting good at it were now deployed into the hospital setting. So there's been a constant sort of flow of needing to retrain or continuously train, not even retrain, different sets of providers and staff into how to implement telemedicine. The other thing that's happened is we've needed to support our patients to be able to use these tools. So patients don't know how to, patients are used to and providers are used to having face-to-face visits, but how do you start or initiate a telephone conversation that's a visit, or how do patients initiate that? How do you talk about things you might have normally talked about in a exam? And it may be intuitive for some individuals, but this is a large behavioral shift that people aren't used to, and so we need to understand what are ways to help our patients as well as providers, optimize these interactions. Our labs also shut down for similar reasons, so we've had very limited or no lab capacity except for very urgent situations. And so one of the things we've tried to do is, for our PrEP patients, we're now mailing 3rd-generation HIV test kits to their home for self-testing. This is not ideal. Ideally, we would have 4th-generation serum testing, but in this context of having extremely limited lab capacity, this has been one workaround. But again, there's been logistical challenges with needing to acquire the home testing kits that we weren't used to stocking, and then having to mail those to patients. And then also thinking about privacy issues and a lot of our patients live in crowded households, so thinking about a lot of those concerns. And and what I want to show you, so this orange graph shows what happened to the number of telehealth visits. So we essentially went from 0 telehealth visits before mid-March to a steady flow of over 1,500 per day. And the yellow graph shows what's happening to video-based visits. And video-based visits, as we implemented our app to be able to have interactions with videos has, slowly increased, and we expect it to increase even more in the coming weeks. For our HIV patients, so this graph shows the total number of encounters we've had for our primary care HIV patients, which is, so out of 1,000 patients, over the last 6 weeks or so, we've interacted virtually with 748 of our patients. So there's been over 2,000, close to 2,500 total communication interactions. There's been, and these are data from March 15th through May 5th, so yesterday. We've had over 1,600 telephone interactions, so these are not telemedicine visits, but these are any kind of telephone interaction that the front desk may have. So a lot of our front desk staff have been calling patients to inform them to not come for their appointments, but their providers would call them or asking them if they needed anything. We've also had a team of medical students who've been assisting, as providers were being deployed into the inpatient setting. We've had medical students who've been using scripts to call a lot of our patients to check in on them and provide care, especially to those who are most at risk of adverse health events, and screening for things such as food insecurity, housing stability, or other needs that they may have, and trying to link them to local resources. We've had almost 800 telemedicine visits with our HIV patients, and of these, majority 756 were telephone-based visits, and 34 to date have been video visits, but we expect these to increase quite a bit over the next few weeks. Again, already talked about this, but we've had limited lab capacity, and another reason for the restricted or minimal in-person visits, even for the providers that are in clinic, are lack of PPE and need to preserve PPE. So this has been a huge issue in New York and in the US, and given our tremendous numbers of inpatient hospitalizations with COVID, we've really needed to preserve the PPE, and so really minimize non-essential use. Some questions, moving forward and looking ahead and sort of wrapping up is, thinking about patient, one area to think about is patient-provider interactions is, how do we build on what we're learning? What are more effective ways to have a virtual encounter? Other things to think about in this virtual model is issues that may exacerbate disparities, which I'll get to in a moment. I think much more research is needed on optimizing communication. Thinking about, can we use aides, support system, family members to overcome digital literacy barriers for our patients? But this may pose significant challenges for patients living with HIV, especially if they're not out about their status or haven't disclosed their status to others or don't have other individuals who are living with them. In the US, we're seeing, and globally, an aging HIV population. And so what does that mean for this group of individuals? For a lot of our elderly patients, they might have caregivers who are able to be there, and there isn't an issue talking about their care for their diabetes, but if they have HIV, how do we deal with those privacy concerns and overcome some of these barriers for our most marginalized patients? Another sort of area of concern is thinking about bias. So what happens when a provider sees how a patient may be living, which, a patient comes into our clinics and they present themselves often the way they would like to present themselves, and we interpret that to mean whatever we do. But now we're seeing patients in their homes, and that introduces a new vulnerability that hasn't existed for the most part previously, at least in the US. So, what does that, I'm not sure what that means, but I think we really need to critically think about, how may that introduce biases, implicit or explicit biases, and how care is delivered and how we make judgments about certain issues for our patients, depending on what we see in the background of their homes or their living conditions. Thinking about disparities, there's lots of opportunities with telemedicine, I think, and moving forward, I really think we need to think about how we reorganize care and how we can make it better, because the care system in the US just has not been working for the longest time for some of our most marginalized and vulnerable populations. But at the same time, with telemedicine virtual care, for whom does the technology work and for whom does it exacerbate disparities? So think about age issues, digital literacy especially, access issues, so data plans, compatible devices. What are the limitations of telephone and audio and video technologies right now and in the future, and how can new technologies overcome some of those things? So thinking about, needing, for example, lab data. Are there ways to integrate point of care lab testing in the home that can feed into digital systems? And I think a lot of us are using some of these technologies for research, especially in remote settings or low-income settings. And can we really think about ramping that up and integrating that into care now for our patients? And the other thing is, what can we proactively do to ensure equity? So rather than studying this and documenting once again that we see disparities in X, Y, and Z, we see disparities among the most marginalized patients and worse outcomes, but after implementing telemedicine, what can we proactively do while implementing these tools, because they're here to stay, and thinking about over the next year, especially in New York City and probably in many parts of the world, what can we proactively do to help ensure equity for all of our patients, especially those who are most vulnerable? There's a lot of new opportunities, and I think there's a lot we can learn from, especially low and middle income country settings. For the longest time, they've had to work with limited resources to provide the most amount of care. And in South Africa, there's these pharmacy dispensing units that have been starting to be implemented, which are an amazing tool. And thinking about, perhaps we can really scale these in our communities where there's limited interactions with other individuals. So there's limited possibilities for transmission of, whether it's COVID-19 or whether it's other new and emerging infectious diseases or other conditions. And these are relatively low cost. They're not staffed, and they can be placed, all over the place. And thinking, we are already in New York and in some other urban areas, we're seeing some of the pharmacy chains implementing some of these kiosks for over-the-counter medications. And so perhaps there's ways to really rapidly implement these tools for prescription medications. For lab monitoring, dried blood spots, for example, are available to measure viral load, and this has largely been used in research settings. And there's been several studies now looking at feasibility of implementing this, outside of research setting and care delivery or for different populations. And finding that it's been highly feasible. These technologies are improving, so perhaps there's ways we can now, rapidly use these tools, just much like we do with home, like finger stick monitoring for diabetes or blood sugars, for viral load and other essential labs for HIV, so we overcome these barriers to needing in-person lab visits. And it may even, reduce the burden on our patients of sort of the travel barriers and all of these other issues. So, I think there's real opportunities to really look hard at what we've been doing in the research world, what we've been doing in other settings, to think about how we can implement these to scale now, to overcome care limitations for our patients. So with that, I'd just like to say thank you to a lot of individuals who helped put this talk together, and especially our patients. Thank you.
Thank you very much, Dr. Patel. And again, thank you and your colleagues in New York City who are on the front lines of meeting the needs of people affected by COVID-19. I think it's enlightening to see this experimentation and scale up of telemedicine, including through lifting of regulations, expanding scopes of work, and as important, scaling the uptake of innovations in telephone and video telemedicine. So thank you again. Before I invite our next speaker to present, I would like to let our attendees know that you can submit questions by looking for the question mark icon or the questions tab, both of which are in your control panel. Please start submitting your questions now so that we can be ready for the question and answer session at the end of the final presentation within this section of the program. So with that, I would like to introduce Dr. Penny, as she is affectionately known by many. We have asked her to speak to assuring continuity of HIV services in African countries, and she is the Africa Bureau Chief for the AIDS Healthcare Foundation, one of the largest providers of services on the continent. Dr. Penny, the floor is yours.
I want to share, what I'm going to share is what has taken place within this first quarter, basically from January up till this point, regards to offering HIV services at the time when we are in crisis mode and have to address the COVID-19 pandemic. And I'll always address this from the experiences of AHF in the Africa Bureau, where we operate in 13 countries across the continent. But before I get into that, I wanted to be able to share with you what the statistics are like so that we can have this at the background of the discussion. The regional data for Africa from UNAIDS 2019 report, from that data we know that sub-Saharan Africa continues to bear the largest burden of the disease, 56% of the HIV disease burden in sub-Saharan Africa. And as of the end of last year, we saw that there was 61% new infection still taking place in Africa. But also, on the other hand, we've made strides in regards to people who are living with HIV and AIDS who are receiving ART. That close to about 50% of those, the total number on ART are from Africa. So we've made great strides over the past years in regards to placing more patients on ART, especially with the test and treat policies that were enlisted and are in place throughout the whole continent. And so with these 25 million people living with HIV and AIDS and now having to deal with COVID, sets to mind what challenges we were likely to facing currently. And at this point in time, as of this date, the Africa CDC report for the statistics for COVID-19, since the first case was confirmed in Egypt in February, to date we have just over 49,000 confirmed cases of COVID, with 16,000 recoveries, with close to 2,000 deaths. And of the 55 countries in Africa, 53 are impacted, and Lesotho and Western Sahara at this point have not reported any case. We don't know whether that's the true situation or is it because of the lack of testing, which is still very prevalent. Testing is still quite limited in our situation. So that puts to mind, where we are in regards to the HIV epidemic and where we are in regards to COVID, just briefly. In terms of where we operate as AHF, we operate in 13 countries across the region. Majority of those countries are in the Eastern and Southern Africa region, which of course are the most impacted by the HIV and AIDS epidemic. And through this region, through all 13 countries of operation, we are taking care of 668,000 patients to date. We don't do this alone. We do this in collaboration with national governments and other NGOs that are working with these countries. And we are able to offer ART care. We are able to build the infrastructure in a number of these facilities. We work in government facilities mainly. So we're able to build and improve the infrastructure in these locations, hire staff to be able to support, the limited HR that we tend to find in most government locations. We're able to provide operational support for key aspects of the program, right from prevention, care and treatment, and follow-on support. So we cover the whole spectrum of the HIV and AIDS service delivery, and we support government by filling in the gaps that we find in these locations. So in my presentation right now, where are we? I want to discuss briefly where the challenges we already had in the ART clinics even before the COVID pandemic arose. Because of the large epidemic in Africa, clinics, we take care of a large number of our clinics, large volume clinics, where we have very many patients attending. We've been in operation in Africa since 2001, where we started operation in South Africa. We all know that South Africa has the highest disease burden. Our largest clinic is in South Africa, and it has over 15,000 patients. And we have similar clinics across the countries that we operate in, where we have a caseload of between 5,000 to 15,000 patients attending the clinic. And typically what we see is that much as we schedule patients to come for particular appointments, there's a lack of adherence to appointment times. So in a situation where you have COVID, you find the majority of patients are coming in before 11. You have more than 60-70% of patients coming in before 11 a.m., which leads to crowding in the clinic. And so overcrowding is common in the clinics. We also find that in a number of locations, there is limited space for clinical care vis-a-vis the patient volumes. And so you find a number of individuals, patients are crammed into small spaces. And then I talked about the, AHF filling in the gaps for, supporting staffing, because staffing challenges are common across the board. And so this presents another challenge where you have to deal with HIV, and then you also have to deal, with the new pandemic. And generally, there have been shortages of PPEs. I think this is a common story across the board for many countries and many regions. And because, of what COVID presented, you find that we've had to refocus our energies on ensuring that patients still get, critical HIV support. But then, we've had to curtail the provision of other services. For instance, monitoring tests have been reduced. Linkage care services have been reduced. Some of these are because of the restrictions that have been put in place by governments, of course, to protect the public and to protect the patients and the people of each country. So we've had to focus our energies. Also for HIV testing, for instance, at this point in time, can only be done at the facility level. We no longer have community approaches for HIV, which would tend to bring together large groups of people. So that's a situation that we had prior to COVID, and we are facing at this point, amongst many others. But these are some of the key challenges. So, for instance, in this slide, I just want to share with you the data for Saka ART Clinic. This is another clinic in Uganda here, which has over 14,000 patients, active patients. And this was the patient load for April. As you can see, on average, there were over 300. On most days, there were over 350 patients attending the clinic. And on some days, over 500 patients coming through the clinic. Days where you see the patient numbers are low, April 10th and 1st May, April 13th. That was the Easter weekend, and 1st May was Labor Day. So those are days, the public holidays, where the clinics, usually will not operate and will keep a skeleton staff. But generally, this is really to show the picture of, the patient load that is expected on a particular day, and for most of it, on average, it's more than 350 patients. So in looking further at the data from Masaka still for April, we because of the epidemic, we changed our strategy to more of a dispensing mode to ensure that what we really wanted to ensure was that patients have most of their drugs, that they do not need to come to the clinics that are already crowded, because that presents an equal danger for them. They're meeting in a crowded place where prevention methods that we're putting in place against COVID and social distancing become hard to enforce. So we've been trying to ensure that we can dispense and ensure patients have medication and keep away from the clinic. Since majority of our patients, over 70% of the patients we see now, are stable patients anyway. So you can see that despite the efforts that we made during the month, there's still a big gap that we need to address. We still have over 200 patients, on average, coming through the clinic. Much as the efforts are beginning to pay off, but the patient load just generally is very high, which puts extra pressure on the staff to devise means about how to ensure there is social distancing, that patients are protected, that hand washing is taking place for each individual walking through. So the patient load generally presents a big burden on the current efforts for COVID, but also, when you're trying to protect the patients. As I mentioned earlier, this is a graph that we reviewed for basically looking at all the locations where we're working across the world, in the Africa region, Asia, and Latin America. And typically the graphs were very similar. Arrival times at the clinic, majority of the patients, as I mentioned, are coming in before 11 a.m. And so there's a lot of crowding before that time. Despite efforts that have been made and in trying to spread patients across the day up till 5 p.m. when most of our clinics work, patients have a tendency to come in early morning for a variety of reasons. One of it includes, transportation. A number of patients will come from locations where transport is, one vehicle will come in from their location in the morning and go back at around lunchtime. So they have to make sure that they can catch that vehicle before it leaves them. For other locations in the Asia region, for instance, there was the issue of much hotter during the afternoon, so patients prefer to come in a lot earlier. But also there is a general mentality, knowledge, especially in Africa, that health workers, in the afternoon, most of the afternoons, especially in government facilities, are not available. And so you can only catch them in the morning. So patients will try and come in earlier to be able to get their provider. And this poses a special problem, for crowding, which is still dangerous even for HIV clinics, because when you think about, TB, the risk of TB. But with COVID, where you want to ensure that patients are spaced out and you're not seeing them at the same time, this has presented a special problem that we've had to deal with. I mentioned that we've had to set aside, we've had to curtail other services that are vital for patients, for patient care. One of these is the viral load monitoring, especially in a number of countries. And the reason for this is we depend on a national hub system where we have a number of samples that are received from a number of locations, health facilities, and they go to a central hub. But mainly because, the services have been curtailed, there's been a lot of more focus and shifts, of health workers to provide services, for COVID-19 tracing, testing of samples for COVID-19. It has had a negative effect on provision of services which are essential, like viral load monitoring. We hope that this will improve, but right now we are doing less than half the targets we have in a number of locations, because the whole system, there's been some level of disruption of the system of taking samples, moving samples, and getting back results. And this is an ongoing challenge, but hopefully that this will improve as governments get a better grip, because we depend a lot on government for the viral load testing. But as governments get a better grip and understanding of their response to COVID, we are very hopeful that some of these other routine services can equally improve. So despite these challenges that I have listed, that we already had and that COVID has presented, what have we done in terms of our response? So our main aim of our response was to ensure patient safety. And we've done this in a number of areas that I'm going to be talking about later. We also wanted to ensure that there is access and availability of sufficient ARV doses. We do not want the patients to keep coming back to the clinic, because that poses a threat to their health and also poses, it predisposes them to more frequency of getting COVID, in case we have cases within the facility or as they come through to the health center. But also in a number of locations, there have been restrictions on transportation as part of the measures against COVID. And this has limited their access to ARV medications. But our aim was, to use the different strategies, which I'll discuss later, to ensure they have enough ARV doses. Fortunately enough, most governments have also changed the policies. In a number of locations, governments will allow you to provide ARV medications for up to a 3-month. The policies to provide the ARV medications for a 3-month period for stable patients. But they've been flexible enough to increase that to a 6-month doses. The other important aspect was to ensure staff safety and to also improve their knowledge, because if our staff are not healthy, then who will provide the services, the much needed services for patients? The aspect about knowledge is very important, because we are all dealing with a new disease, and being able to share information. A lot of information has been coming through. So being able to share the information with them quickly has been very important to get them prepared and to know what to do in case patients living with HIV, and also in case some of the patients living with HIV get COVID. Another important aspect was to enhance community knowledge on COVID, because the reality is there's a lot of misinformation that has been that people have received, especially at community level. There are also a number of myths and beliefs that are in the community that actually are affecting the response to COVID. Most of the knowledge and information regarding COVID has been centrally managed through government. So we are partnering with government to be able to share, to be able to work with different communities to take this knowledge to them in a way that they can be able to understand. Using community radios, using their local leaders to get the information across in a language that they understand. We also thought it was important not to reinvent the wheel, but to harness past experience in dealing with Ebola to shape our emergency response. In Sierra Leone, at the height of the Ebola epidemic, we faced similar challenges that we're actually facing right now with COVID, where we had to get patients their medications because they were afraid to come to the health facilities. Some of the health facilities we worked in Sierra Leone were taking care of Ebola patients, so patients were afraid to come there. And we had to use community networks to take those drugs, to get the drugs to the patients, or to dispense in locations away from the health facility, like the offices of the National AIDS commissioners in the different locations. So being able to use that experience, they've also dealt with lockdown. So being able to harness some of the experience and deal with the situation we have at hand right now. So some of the things we've done, one, in regards to the emergency cycle. On the preparation side, this was always supposed to be and was a patient-centered response. So whatever we did was to ensure that the patient was at the center of our response, whether it was procurement of PPEs for the staff, whether it was buying ARV medications. Our approach was to have the patient at the center of the response. And we also enhanced our communication and information sharing. And through that, we had emergency response plans, because what we found out is that it was important for our mindset to change. We were being used to providing ART care for many years. And so we have a kind of normal routine to that. But this was an emergency that we are dealing with, and we equally had to be prepared. And so ensuring that we had plans at different levels, from the top senior management level to the country level, right up to state level, and holding different teams responsible for each aspect of the plan, whether it was infection control, whether it was logistics management, whether it was patient education, help to galvanize the teams around, a common theme of having the patient at the center with different aspects that, were to support the patient. We also had ensured that we had a communication tree. And this was important because so much information has been going out. Our staff have access to information from the internet. They have access to information from all sources. A lot of it is unverified, and some of it they were taking it, without verification. So we ensured that we had channels through which we were providing information that is verifiable, whether it's on the patient data, whether it's on new information we are getting about your patients, as something that they could actually, from sources that they could actually trust. So, and being able to channel that through particular individuals and not through everyone, but making sure that everyone receives the right information at the right time. Enhancing that communication also meant that that technology was very important to us. And so we've used different platforms. One for education, we've used an e-health education platform to provide that information. We've used WhatsApp a lot. WhatsApp is very common in Africa to get information to the staff very quickly, whether it was short videos on hand washing, or how to wear a mask, or what symptoms of COVID. That enabled us to get information out there very quickly, and to ensure everyone was on the same page. On the response side, as part of our emergency cycle, so we created response teams at different levels, as I had stated. And the other important part was to have inter-country and interdepartmental collaboration. The reason I mentioned this is one of the key areas this has been important is especially with procurement of PPEs. And in most countries were already stocked out of PPEs even before they reported the first case. And mainly because when the epidemic was ongoing in China, a number of middlemen within the region were actually procuring those PPEs, holding them, and actually sending them back to China. And so by the time the epidemic was being reported here, we were already working from a deficit in regards to PPEs. The procurement of PPEs itself has been very important. And one country supporting the other. For instance, South Africa, we have a larger base of vendors supporting smaller countries like Lesotho and Eswatini, because in those countries you could not get any PPEs. So that collaboration has been very important as part of the response, and it has helped to ensure that our staff and the patients will have protective gear available for them to use quickly enough. I talked about the importance of the education on COVID. That is critical and is always ongoing because new information is coming up every other day. The multi-month prescription of ARVs has been very critical. One, with support of governments changing their policies and going over and beyond just changing policies and being very flexible. For instance, in South Africa, we've seen a government gazette that is going to pilot using community pharmacies to dispense medication. So that will help to ensure that patients do not have to keep going back to their facilities and crowding the facilities while getting medications. And that alone, multi-month dispensing, has ensured that we don't have patients coming through the clinics on a regular basis, so every month or every 2 months. That helps to reduce the crowding and helps to reduce the risk of them catching COVID along the way. The other key critical issue that has arisen is the issue of food security. This specifically has arisen because, in areas where there's been a lockdown, in a number of countries have implemented one form or the other of a lockdown. Some of the lockdowns have been more strict in Uganda, Rwanda, South Africa. I think had periods when the lockdown is more strict, and And so you find that the number of the patients to take care of are poor patients who live from hand to mouth. So they have to work for that particular day's meal or food for their family. And so food security has become a real issue that needs to be addressed, that we are addressing amongst our own patients, because we do have a number of vulnerable populations in many locations. And so that's a critical part of the response. So as a continuation of the emergency response, the things we've done at the facility level, implementation of infection control procedures, hand washing, wearing masks, social distancing at facility level. Much as there's been a shortage of space, there's always been shortage of space in the number of facilities. We've managed to hire tents and place patients in tents, ensuring that the social distancing that can be, observed at that point. We are in the process of procuring masks for our patients to ensure that when they're coming into the facility, they will not give excuses of not being able to afford a mask. So we will expect them to wear the mask. And hand washing is something that has been implemented all through. Then we've been able to deliver medications at home for a number of our patients. And because most of them could not get to the facility, it was either too far from them because of the lockdowns where public transport was banned. So we've used either community ART groups, we've used their peer support groups, we've used the motorcycle deliveries and more modes to get patients their meds. We've taken, we've had outreaches closer to the patients' homes, in churches, in schools, to get the drugs closer to them and make it easier for them. As I said, the prescriptions we've been giving for 3 to 6 months. We've shared information on WhatsApp and e-health education for staff and procurement of PPEs. So I want to share with you these pictures from our clinic in South Africa, Int'l Clinic, which is situated in Umlazi, in Durban. These just to show that we, despite the challenges we may have, this clinic is the one that has 15,000 patients and also sees about 500 patients coming through on a daily basis. But we've been able to implement some social distancing within the clinic, have multiple points for dispensing medication so that they're not all going to the pharmacy as they used to. We're able to, dispense some of the medications out in the tent, so that then there's no crowding within the pharmacy. So, it's possible in some locations, and especially if you have, get the patients to understand why this is important and to also have the understanding of COVID. These are some of our tweets from our clients. In Uganda, there's a safe border delivery means, which is a motorbike delivery service. And so we've been able to utilize them to take medications to patients. So the patient doesn't have to come to the facility. They can actually send the motorbike rider with their prescription refill or their patient card, and the staff give the delivery to the motorbike rider to take to the patients. We've also had our own patients who are supporting other patients. They go out on a bike and are able to deliver medications to some of the most vulnerable patients. So all these means of home delivery of medications are available. Some of them was not tested before, but we've seen that we have been very effective medications out there. One of the in regards to part of the recovery cycle, our ultimate goal is to ensure that we can protect and preserve, the safety of our patients, and the health workers' recruitment is going to be very paramount, will continue to be, because we don't know how far, and reaching this epidemic will be. But we want to ensure that the patients can continue to get their medication, that they'll stay safe in their homes, and the health workers will continue to be safe. We also learned some key lessons, and some of those is to ensure we can adapt them, to ensure we are more efficient in delivering treatment close to communities. There is no reason why a patient has to come every 3 months if they have no ailment to the health facility and keep waiting for hours on end just to receive a prescription. The previous speaker talked about pharmacy dispensing units. We are also in the process of piloting that because closer to some of the communities where we have very light clinics. So we want to pilot that in a number of countries. We also want to continue to enhance ARV distribution channels, for instance, the community pharmacies. They will help to relieve the burden on the clinics and continue to enhance home delivery of treatment using community ART groups, motorcycle or bicycle deliveries. Basically document the lessons we are learning. We are learning on our feet, as I would say, about this epidemic and how we can become more efficient. And ultimately, in regard to our mitigation plans, we do need to review what the world is doing as a whole in terms of public health. So the Convention on Global Public Health as an advocacy agenda for us is very important. Some of the ongoing challenges we are facing, much as we've been able on the whole to get patients medications, we still have ongoing challenges that we'll continue to deal with. Patient facility is one about that being an ongoing challenge. But one of the critical challenges we face is that much as at the point of entry into a facility, enlisting into a facility, patients will provide us with a phone contact, one for the patient and one for the attendant. We found that majority of our patients, their phone numbers are actually invalid. In some countries, like in Rwanda, in our Rwanda program, only 5% of our patient population had valid phone contacts. In Uganda and Kenya, we found only 40% of our patients had valid contacts. And this presents, a bigger problem. It presented a bigger problem for the patients themselves and for us, because we've been trying to contact the patients coming earlier to start their medications. But when they don't have a valid phone contact, then it's harder to get them. So a lot of it has worked, against patients, against the patients themselves, because then they've had now to get to the facility in order to, yet we could be able to deliver them closer if they had a valid phone contact. Most of the patients will change their phone numbers really for issues to do with stigma. They will not want the clinic to follow up with them, or they think someone else may find out that they're getting ARVs. So it's really an issue of stigma, and we're trying to get them to understand, based on this pandemic, that a valid phone contact works in their favor at all times. So that has been a key concern, and I think at the end of the day, we'll not be able to reach many number of patients, mainly because we do not have phone contacts. In a couple of countries as well, there's been an insufficient ARV stock. There have been some insufficient ARV stocks, mainly because of being lockdowns in China and India, where we get most of our medications. So those are situations that countries are dealing with to try and get more medications. But that has hindered us from giving multi-month prescriptions for some countries. Generally, misinformation about COVID is a bigger problem that we are dealing with. But as more information gets out there and we get more to the community, the information is being verified and the community is able to understand, what COVID is about. The misinformation itself has led to stigma regarding COVID. In a couple of locations, Uganda being one of them, you find some either COVID cases or their contacts, have either been beaten up because, the community says you're bringing COVID to us. So and families have been stigmatized, which is really unfortunate. But a lot of it is because people are not knowledgeable about the disease. Food insecurity will continue to be an ongoing challenge. We don't know whether we'll be coming in and out of lockdowns, but for as long as that is going to happen, food insecurity is going to be a big factor. Much as government is pitching in to provide food parcels in many locations, it's not enough. It's definitely not enough, and it may just exacerbate the problems we have with COVID and unnecessary unrest. We've also experienced a lack of community level support due to the lockdowns, because many community-based organizations who you depend on to trace patients, who you depend on to take medication to patients, are able to function, and because they're expected to stay in their homes. So which presents a bigger problem of making medications closer to the community. Stigma and discrimination I've mentioned, mainly because of misinformation or myths around COVID. We will experience loss to follow up of a number of our patients, because we are unable to reach them, and we are not able to have our linkage coordinators and tracers follow them up in the community. And the lack of transport due to the lockdowns will continue to be an ongoing problem, which means patients cannot come to the facility, and it's harder for them, to get their medications. But we'll continue to try and strive to take the medications to them. And lastly, one of the things we observed after the Ebola epidemic in Sierra Leone was that we had a surge in numbers of patients who had failed treatment, mainly because they were fearful of coming to the facility. We could not get to them for issues of stigma. And so we had, after the epidemic, we had a surge in patients who needed second-line medications. We think that is likely to happen, especially in locations where we are not able to get to many patients. And so we are continuing to strive to ensure that patients can stay on medication and stay adherent despite the effects of COVID. And so I'll end there, and thank you for taking the time to listen to me.
Thank you very much, Dr. Penny. Important to see the work that is being done to ensure continuity of HIV services, but also sobering to hear from you about all of the patient and facility level challenges that are being faced. And I think that's a good segue into our last presentation for this section. Before we get to that, just to remind everyone that you have the opportunity to submit questions to the presenters in the first section by utilizing either the question mark or the question function on your control panel. So please feel free to submit questions. Regrettably, Rico Gustav, who is the Executive Director of the Global Network of People Living with HIV, is not able to join us today, but I've given the importance of community engagement and listening to community, I asked his permission to present at least the beginning part of his presentation, because I think it's really important for us to hear what GMP Plus has been hearing from people living with HIV through a survey that was conducted from 47 networks in 30 countries. So I'll just very quickly go through the first several slides of his. Next slide, please, to illustrate some of what community is trying to convey to us as not just providers, but their advocates. Here we hear from the Sarma David Legacy Fund in Pakistan, a feeling that there is no equality, no freedom, no justice, no wider or basic human rights associated with the COVID-19 response in Pakistan, and a real need to address this inequity. Next slide. Turning to Ukraine, our colleague at the All-Ukrainian Network of People Living with HIV are reporting that due to risk of ART stockouts, the drugs are given to most people living with HIV only for 1 month, which causes a significant amount of additional stress and difficulties for patients in terms of quarantine and lockdown orders, much as Bob addressed in his talk. Next slide. From Kenya, we hear there's a challenge of hunger and starvation, especially among people living with HIV in the Nairobi slums, who usually depend on low-level casual work to make an earning for food. We've heard already this morning about fears regarding social distancing, disinformation, but also fears regarding curfew and how that might intensify poverty and hunger among people living with HIV. And so speaking to some of what Shannon mentioned in her solidarity remarks, addressing the longstanding inequalities that exist in our society, both social and economic inequalities, this has been brought to bear as a result of COVID-19. Next slide. From Mozambique, we hear from a community group, Resiliency, about patients abandoning waiting lines and giving up because the health facilities where they are being directed to collect their ARVs are very long and place them in jeopardy of becoming COVID infected. Next slide. And from Jamaica, the network of seropositives, we hear that people living with HIV, as Bob already alluded to, are very depressed and worried that they will die after contracting COVID-19. Again, importance of getting information out there about risk mitigation, but also, of course, of addressing the very real concerns that not only people living with HIV, but every one of us is feeling at this time of incredible uncertainty. Next slide. In this slide from Eswatini, a very tough situation, especially for women who are self-employed. They can no longer go to the street to sell their vegetables, hawkers can no longer travel, and they have families to feed, children to take care of. Next slide. So this is how GMP Plus has identified to us, and I wish Rico was able to join us to really go into greater detail, but next slide. GMP Plus has started a newsletter for people living with HIV, positive living in the time of COVID-19. There are two newsletters already available, and you can subscribe by emailing covid@gmpplus.net. We'll make these slides available. In this first newsletter issued on April 6th, it was information about how communities are responding to the COVID-19 epidemics. Next slide. And as well as the way in which young people are living in the time of COVID-19. Next slide. Finally, the importance of addressing the networks of women living with HIV and some of the innovative ways in which they're trying to maintain HIV services, but as important, sexual reproductive health services and protecting those rights as essential services in the context of COVID-19. So with that, I've done a great injustice, I know, to Rico's talk, but I felt it was really important that we review what the community of people living with HIV is telling us about the reality of COVID-19 within their respective communities. And I think given that, it reinforces in many ways a lot of what we've been hearing from our clinician speakers this morning, whom I thank for their incredible contribution to this section on COVID-19 and HIV. We're going to open now for questions. We have a couple that have come in, and please keep them coming because the Q&A session will end around 3:15. Otherwise, we'll continue with the next section of the program, which is Adherence 2020 preview. So the first question we have from our attendees is, do we have any data for those who are long-term survivors or those who have had an AIDS diagnosis long-term and are also COVID-19 infected? Perhaps this is a question that several of you could tackle, including Amanda, if she's still with us, Bob, Viraj. The floor is yours. Amanda, do you want to take a first stab at answering the question?
Sure, can you hear me?
Yes, we can.
Yes, we can.
Yeah, I think that's a great question. And as I alluded to in my talk, we really don't have that much data on persons living with HIV and COVID-19, it seems that we may actually have relatively low co-infection. You know, in some instances, I think in Spain, there was a paper from Barcelona that was 1% of the population was infected. So I think it's a great question. I think we're going to have to learn more. It certainly seems that individuals who are on antiretrovirals and virally suppressed do better. But again, I think the numbers are so small here that it's hard to make a determination. So there are certainly cohorts being set up to be able to gather that type of information and to look at both the immediate clinical presentation, you know, whether or not these individuals require hospitalization, intubation, and how they fare in terms of long-term sequelae and mortality.
Thanks, Amanda. Anyone else want to tackle that question?
Sure, this is Bob Remian. I also not aware of data, so it is a great question. We're going to have to monitor this very closely moving forward. Jose just alluded to this, and I did as well earlier. I just will say that from a psychological perspective, that at least clinically what I'm seeing, as well as through various networks I work in, that people living with HIV are very, very anxious, you know, maybe even more anxious than some, or they're questioning as well, you know, what is the potential interaction? Am I more vulnerable because of my HIV status? And, you know, what we've been told is sort of basically what you've heard is that, you know, if there's a relatively healthy immune system and no other underlying conditions, that some of the experts don't think that people living with HIV are more vulnerable than anyone else, but it's really just unknown. And my main point being is the anxiety is there. And as I mentioned, there's re-traumatization of even just having been diagnosed with HIV in the past. So the concern is there, the anxiety is there. Everyone's awaiting data to speak to it.
Viraj, would you like to add anything? Not sure he's still with us. So let's move on to the next question, which is directed to you, Bob. Will we see suicide numbers increase in the US and globally due to the increased psych and mental health issues with COVID?
Again, it's a great question. You know, I think that there's an expectation that there's an exacerbation of mental health conditions globally because of this pandemic. So I think any mental health condition, particularly the ones I highlighted in my talk, anxiety, depression, PTSD, suicidal ideation, I mean, any of those can be elevated and exacerbated by stress. So, you know, it's the best I can say is that I think as mental health clinicians, we are on the lookout for it and concerned about people becoming suicidal, but we don't know that this is going to lead to any more suicide, either attempts or actual, you know, successes than any other crisis or tragedy that faces communities in different places. Now, this pandemic is worldwide, so I personally wouldn't be surprised if the numbers don't go up, just like the numbers in any mental health condition will probably be going up. And then the other thing that is a total unknown, but I alluded to it in my talk, is the degree to which the virus is affecting the brain as well as the central nervous system. So the degree to which, remember I made reference to delusions and hallucinations being reported in some people, there's neuropsychiatric. I've heard clinicians that I work with question whether, you know, a few suicides that we've seen, if there was some neuropsychiatric sequelae associated with it, where people were, you know, affected at that level. So these are good questions, and we have to monitor it and be mindful. The one thing I will say to anyone who's concerned about anyone with suicide, one does not give someone the idea for suicide by asking them if they're thinking about it. So if you ever have concern for a colleague or a patient or a friend, if they're expressing serious depression and feelings like life is not worth living, to ask more directly and to try and get help. for that person.
Thank you, Bob. Amanda, and if Viraj is still with us, here is a question that you might want to respond to. Do you have any thoughts on how HIV testing can proceed during this time of social distancing? We believe this is as important as ever, but there are fewer in-person touch points to reach people.
Yeah, I'm happy to start off. I don't know if Viraj is still on, but I agree 100% that we need to be able to, minimize the disruption in some of our preventive services. And I know that there have been, at least in the United States, efforts to start sending out test kits. I think that Viraj alluded to it in his talk, that they were sending out third generation testing for PrEP patients. In addition to the HIV testing, I think also home-based STD screening kits as well are also really important, because I know that some of these essential services have been shut down, at least temporarily. And so those services are not as widely available. And yet people are still people, and they're still at risk, and they're still sexually active. And so we need to ensure that they have access to those types of tests.
Viraj, I don't know if you're still with us. You might want to address the question. I think he may no longer be on. So we'll move on to the next question, though. Then, what do we need to understand about the estimates for the summer and the fall? Are masks and social distancing our new social reality?
I'm happy to start off the conversation around that. And in putting together the talk and talking to my colleagues about some of the synergies and lessons learned from HIV, this was certainly one area where we said, this is actually very different, that, we certainly weren't doing social distancing and wearing masks as part of HIV prevention. And I certainly think that over the next several months, certainly through the summer, that this will become a part of our new normal. Hopefully we will be able to get some type of therapeutics available to treat COVID-19, and certainly a vaccine would be wonderful. But I think until then, we're going to have to continue to implement these types of measures in order to minimize the risk of transmission.
So this is Bob again. I mean, I'm not an epidemiologist nor a medical provider, and so I can't really add much. I think Amanda just gave a really good answer. But I mean, I think what we all know is that I think this will play out, and will likely play out differently in different regions of the world, and even within regions, different sections of those regions. As a New Yorker, it's fully expected, I think, by most of us that it is going to be the new normal for most of at least the remainder of this year, or at least through the summer, and that's what I'm hearing. But that doesn't mean it's going to be the same exact thing in every location.
Viraj is with us. He was muted, so maybe Viraj, you could provide an answer to this question and the previous one.
Yeah. So I didn't catch the last question for my audio disconnected briefly, so I had to reconnect. But for this present question, yeah, I think I agree with Dr. Rem and Dr. Castell saying, it's going to be very dependent on the local jurisdictions and the states and what's going on in what the local epidemiology is. So that's where I think testing is really important and needed to be scaled up everywhere. But in a place like New York, I just don't see in the foreseeable future not using masks and not practicing social distancing to the extent that we can. If you look at Twitter and other places, you'll start seeing pictures of people now and things and not using masks. And, that makes a lot of us nervous, but I think we have to think about, how do we support social distancing and all of these tools that we do have and can use, for the foreseeable future.
Excellent. So Viraj, the other question you missed was related to HIV testing and how it could proceed during this time of social distancing.
Yeah, so we have a HIV outreach program, that's community-based and community-facing. And historically, what they did was they were already doing a lot of virtual outreach. And one of the, and early on, a couple of years ago, when we looked at doing mailing people kits and things, it didn't have a lot of traction in the Bronx. And one of the reasons was due to household crowding. So a lot of the individuals we were reaching online, as well as through events, and that our outreach team was reaching, they lived with families, they lived with other individuals, and so did not want to receive mail at home, especially an HIV kit that someone may see or open, and so there's huge privacy concerns. Thinking about the future, we are able to send HIV kits now to some people, but there's still issues around privacy. Or are there ways we can create these kiosks? I think some places in the US have piloted these things where you create a kiosk so you can get it, whether it's a code or on your phone, you get a code for a free test kit or something. So you can go and pick up a test kit without interacting with anyone. But, I think we really have to think about how do we scale up testing in a totally different way that's not as reliant on face-to-face interactions. And, I don't think and I think we need to do that rapidly, but I think there are some models out there, whether it's here or whether, especially in some other countries, where we should look to.
Thank you. The next question is also for Bob, although if the other speakers are familiar with examples of how what countries are doing for the care of healthcare workers' mental health that low-income countries can learn from to protect the health workforce.
Wow, that's a great question, which unfortunately I'm not going to have a good answer for, just because I'm not, this is all so new. I have not seen data, nor had the luxury of speaking with a lot of people from different parts of the globe about who's doing a better, or who's got some model programs and doing a better job of this. I just don't know. I mean, any one of the other panelists can speak to it. They can, particularly maybe Dr. Penny might be able to, but it's all I can say is that I know from my local situation in New York, and particularly at Columbia University Medical Center, that various groups where there are psychology departments, psychiatry departments are rallying to support their hospital staff, but I do not know how this is unfolding across the globe. Sorry.
Anyone else want to tackle that question? Unfortunately, Dr. Penny is no longer with us, but anyone else?
So I can describe what's going on with our healthcare system. We don't have outcome data, of course, but some of the things that our institution here in New York and the Bronx are doing is to support one another and support healthcare providers is, first is changing the way we deliver care in the sense of trying to give our residents and physician staff as well as nursing staff shorter shifts. So instead of, for example, if you're working usually you work for 2 weeks in a row, perhaps you work 1 week in a row and then have a few days off and then you're back in the hospital again. Or you have 1 week on, 1 week off. So restructuring care to give, some downtime to process everything that's going on and just to collect yourself and have self-care. Another strategy is our psychiatry department and mental health department so which is made up of social workers, psychiatrists, psychologists, have all been assigned to various frontline healthcare workers, and they've proactively reached out to each of these healthcare workers to have check-ins by email, text message, phone calls, video visits, whatever the individual, and so it was up to the individual then to respond and say, I'd like to have a check-in, or I'd like to talk to you, or just ignore it, or whatever it is. But every frontline healthcare provider was assigned to an individual, and I haven't seen any data yet as to what the uptake has been, or but a mental health provider might have been assigned to 20 individuals or 30 individuals, but it's unknown what the uptake is and what the outcomes of those things are. But otherwise, I think just really thinking about self-care and what that may look like in different settings, it's probably one of the more important things to do. But
Thank you. And if I can just elaborate real quickly, I mean, with specific examples of like what we're doing, like what Viraj Patel just said, is we have we're doing outreach to all the different departments in our hospitals, so that we're doing like just sort of talks a little bit like the content of what I shared with you about how people can do self-help. But then we are offering group sessions, being typically led by a psychiatrist and a psychologist or a social worker. And then we also offer one-on-one counseling sessions to each department. And so the department heads share this information, people sign up. These are not quote unquote therapy, they are simply a check-in session. But then if someone does need more serious mental health care, a referral is made to a provider within the hospital system. So we're doing that just very proactively. And many of you may know it was in the news about an emergency room physician that committed suicide at our hospital. And after that, for instance, that was a department where what our task force actually did was an opt-out, where everyone in that emergency department, because there was a lot of distress and stress after that suicide, she was a beloved individual, we did an opt-out where people were signed up to have a check-in with a mental health care provider, just as a check-in, and people could opt out of it, but everyone was signed up for that. So that was an example of a very proactive way of reaching out to that department.
Thank you. We're going to take two more questions. The next one I'll direct to the group. The last one I'll address myself. So do you see a positive perception in the term of physical distance versus social distance? What is your opinion in an emotional point of view?
I'll start us off. I know there's been a lot of debate about which terminology to use. Again, I'm speaking from the US perspective, that I often am saying that even though we refer to it as social distancing, it certainly should not mean social isolation. And as we've just talked about, it's so important because of the mental health stress that the virus and this pandemic are putting on everyone across the globe. So I believe that some of the international organizations are calling it physical distancing, to try to minimize the idea that we cannot be social during these times, and we certainly can find different ways to be social without being in physical proximity with others.
I would definitely echo that. I'm glad you said that, Amanda, because I've been thinking all along myself, why is it not being called physical distancing? That's really what we're talking about, the physical space between people, not the social space between people. So I just really wanted to echo that, underline that. And also if it's framed in a way where this is how we take care of each other. We're doing physical distancing because, that's mutual taking care of each other, right? As is wearing a mask. but certainly it should not be social distancing, as Amanda clearly said.
Yeah, I think I don't really have much else to add. I agree and echo what the previous two individuals, Dr. Castell and Ramian, have said. And yeah, perhaps we should really think about rebranding it to physical distancing. I like that. But again, proactively think about ways to reduce social isolation, because we know isolation is a huge determinant of poor outcomes for all sorts of health issues.
Well said. Did we lose Jose, or is he on mute?
Hello, can you hear me?
Yes, we can now.
All right. So thank you, all three of you, for your response to that last question. I'll tackle the last one, if you don't mind, before we transition to the next section of the program. And it basically is that we're dealing with a lot of complex cases among individuals living with HIV who are undocumented migrants, or those going through the asylum process in Europe, who are mostly living in situations where social or physical distancing or isolation is not a reality. We're being asked what, as a forum of clinicians, we can do to support a strong statement to governments to understand that these communities also matter. I'll speak on IAPAC's behalf, and I know that Shannon addressed this from UNAIDS' perspective. There's a tremendous amount that clinicians and allied healthcare professionals can do to advocate on behalf of the needs of all people living with and affected by HIV/AIDS, especially the most vulnerable. There is a movement afoot to draft a global health security statement that would be signed on to by various governments around the world, so that we are better prepared for pandemic situations such as this. It is not true that we did not see this coming. We saw it coming. We had plans that should have been implemented in a more expeditious manner. And unfortunately, as a result of colossal failures in public health, we face the situation that we do. But there is, I think, a responsibility that we all bear, those of us in public health, clinicians, community, to stand up for the rights of all people, particularly those who are living with poverty, anxiety, hunger, fear, and a sense of hopelessness that can become paralyzing in some instances when we are faced with the unknown. So with that, I would like to thank our speakers for the COVID-19 and HIV section of the program. If we were in a room together, I'm certain you would receive a standing ovation for what are just remarkable presentations. I thank you, and with that, we'll transition to the next section of the program, focused on 3 presentations that would have been delivered next month at the Adherence 2020 conference, but that we felt, as I noted this morning, were so important to preview here to assist those of you who are treating people living with and affected by HIV and AIDS within the COVID context. So we'll start this section with Dr. Catherine Orell, who is also co-chair of Adherence 2020 with Bob Remian. She is with the University of Cape Town in South Africa, and we've asked her to speak to how we optimize adherence to antiretroviral therapy within disrupted health systems. Catherine?
Thanks, Jose. I hope you can hear me. I'm just going to make my screen bigger. I am going to speak on optimizing ART adherence within a disrupted health system. My talk will give a South African focus, and unfortunately does speak a lot to the COVID-19 epidemic, which has added strain to our already stressed healthcare system. And a number of my points have been made by other speakers, but I hope I will bring another perspective to that. So in South Africa, our system is already under strain. We have 7.5 million people living with HIV. And now on top of that, we have this new pandemic of COVID. As yet, and I'll come to this in a second, we don't have that many cases, and I want to speak about mitigating and aggravating factors that might apply for South Africa. But what we have had, and what has been a huge disruption, is our very heavy lockdown. And the impact, I'll speak to the impact this has on both our healthcare system and on individuals already struggling, as Dr. Penny said, with poverty and hardships in their life. So in South Africa, we're still in the very early part of our COVID epidemic. As of yesterday, we've had 7,000 cases and 138 deaths. More than half of those deaths are in the Western Cape. We've also had a hard lockdown since the 27th of March, which is essentially meaning that we could only leave our homes unless we were essential workers to go shopping. And as of last week, we eased into level 4, which is essentially means you can now buy clothes as well as food. And you can order takeout foods, but we still can't leave our homes. And many people who rely on casual work, domestic workers, gardeners, people like that, are not going to be allowed to go back to work until, and we actually have no idea when that's going to be. So we have a very strict lockdown, which is having enormous impact at all different levels of our healthcare system. So when it comes to the COVID epidemic, we might have some mitigating factors in South Africa. If you can call it mitigating, we have only 5.3% of our population over the age of 65, which speaks to our probably poor social, economic and healthcare systems and inequalities over the past 40 years or so. We also potentially have some cross-effective immunity, repeated infections from people living in crowded spaces with other coronavirus species. There are some questions about genetics and HLA types. We know, for example, that there are differences in the ACE2 receptor in sub-Saharan African population, although whether that is going to be mitigating or aggravating, we actually still don't yet know. And because of the fact that we had such a hard lockdown, we've also had time to prepare. My hospital at Pretoria has cleared out wards, made spaces available. We have rosters for clinical staff set up in advance. We have testing centres prepared and tents out the front. So hopefully we had time to mitigate some of those factors, at least on a health system level. Next slide. So the aggravating factors in South Africa are 48% of it. We don't know what the impact of COVID, as previous speakers were saying, what COVID and HIV are going to be. And in our setting, 48% of those living with HIV are not virally suppressed, made up of groups of people who have not started treatments at all, and then groups who have been a group who have started treatments and have been lost to care, or who are poorly adherent to their medication. We also don't know the impact of our TB epidemic. It's an endemic, certainly in the Western Cape. We have people who have current TB, and then also a whole swathe of people who have previous TB lung disease, bronchiectasis, and other who may well be, who may also be at higher risk of a pneumonic illness. We're not far behind the US in the proportion of people with obesity. We have 6 to 12% of our population with diabetes, and many people who are over 60 also are hypertensive, and there are other cardiovascular diseases as well. So potentially the epidemic could hit us particularly hard. Next slide, please. Look, this is a slide from April the 29th, looking at hospital sentinel surveillance at clinics and looking at people in the Western Cape who have died who are under the age of 40. And what worried me a little was the Tygerberg Hospital case at the bottom, where there was a 41-year-old man who had HIV but was virologically suppressed. I was listening to a talk from the the provincial data centre today, and we have at the Western Cape at the moment of the cases there, we've identified 352 people with HIV, of whom 9 have died, which is not many, but half of the people who died with HIV were virally suppressed at the time. So we don't have CD4 count data, but it is a little worrying that people who are virally suppressed are potentially becoming very unwell with and dying of COVID-19. Next slide, please. So, so also talking to the impact of an aggravating factor for our system is that communities are crowded. So physical spacing is very difficult. And if you're living in a shack or a house made of zinc, it's often not airtight, and there could be 4 or 5 people in a room, and another family just on the other side of a zinc wall. So physical spacing in our setting is a very difficult thing to ask. In fact, and then keeping people at home is also a very difficult thing to ask when that is all the space that you are allowed to be in. So we're still waiting for the peak of our epidemic to come. Next slide, please. So what is the impact of, so as I said, at the moment we haven't been impacted by COVID-19 itself, but we have been impacted by preparations for COVID-19, including the lockdown. And this has included threats to our supply of ARVs. It is hard for people to get to clinics. I know Dr. Penny spoke to this and showed some pictures of people spacing their chairs inside the clinics. But what's happening in the Western Cape, and certainly in 2 or 3 of the clinics I've seen, because people are trying to space within the clinics, it's causing crowding outside the clinics. And I have had patients standing in a very long line in a long queue outside the clinic, which was far from ideally spaced. There's also been a much worsening of waiting time. One of my counsellors has been called by patients who take the medication from Guguletu, complaining about long queues, they're too old to stand for the day, and they're asking about maybe field workers can deliver. Other patients saying she's running out and she took her last pill, and they were all shouting at her. So there's a sense of desperation, and people don't actually know what to do. I had one patient who waited the whole day and didn't get let in by the end of the day, and then went back the next day earlier and then was told it wasn't his date and he couldn't come in. So there's a sort of lack of flexibility in the clinic, and the fact that we've been told to physically space in the clinic is actually causing harm outside the clinic where people, you know, are still waiting. Next slide, please. As Dr. Penny spoke to, the supply chain has been disrupted. So with the restricted international and local transport, there's been no delivery of medications. So we currently have a shortage of efavirenz-based ARVs. The majority of our population are still on efavirenz-based antiretrovirals. We're in the process of shifting to dolutegravir. There's also been very little delivery of PrEP. In fact, only 25% of initiations have, this is from IAPAC Africa, a reference from IAPAC Africa, only 25% of expected initiations have occurred in the last few weeks of lockdown. Delivery of PrEP is a fairly recent service, and it also seems to be considered non-essential, despite the fact we have 600 new HIV cases per day. Next slide, please. So there are a number of solutions, but it does require a change in thinking. Sorry, one slide back up, including moving stable people out of the system. So a lot of these solutions are not new ideas. They are things that are being slowly put in place because of the overcrowding and pressure on our existing health system, and now suddenly become much more important and more urgent. We are, however, a system that's fairly used to change. We've switched D40 out, we've switched tenofovir in, we've changed starting CD4 counts without extra staff, and we have new guidelines that were released at the end of last year asking people to switch, people who are stable on ARVs, to switch from an efavirenz to a dolutegravir-based ARV system, which is why we have a shortage of efavirenz, because the projection has been everyone will switch to dolutegravir-based treatment, but at the moment only 3% of people have switched, and we're still a bit short of efavirenz, so switching is having to happen in a non-ideal setting, without potentially the viral load that was going to be done to make sure people were suppressed in order to try and space people out. Next slide, please. So these plans that were put out by the Western Cape in a document a few weeks ago, including a push for testing and initiation, but with no plan really for doing that by distance. So it looks like we're being asked to send people to clinics to have them tested and initiated, which might well happen, but then we go back to the previous problem of the clinics being already quite overloaded. Couple of things that should work to kind of reduce the pressure on the clinics is the increase in the ART supply given. We now are allowed to give 4 to 6 months if people are stable, but again, most people are still on efavirenz-based regimens, and that supply is actually limited because of at the point of switch we were when this epidemic has hit. If people are on dolutegravir-based regimen, they can be given 4 to 6 months. We are obviously in the process of trying to differentiate care. We have a number of systems doing that, including adherence clubs, which are nurse-led or community health worker-led and nurse-supported, up to 30 stable patients that meet between 3 and 5 times a year and receive pre-packed ARVs. These clubs can meet in the community, can be socially spaced. You can send some other family and friend members to collect the medication. They're also, people are also exploring facility-based pickup points where you don't have to come and see a clinician, but you can come to a window on the side of the clinic and actually collect your medication separately. We don't yet have the pharmacy dispensing units in the Western Cape, so that for us is not an option. Next slide, please. So what has happened in the last few days is the government has gazetted an increase in the lifespan of prescriptions, which is great. So it means that current prescriptions do not have to be rewritten by a healthcare worker, but can have, if you have their lifespan extended from 6 to 12 months. So hopefully can leave out some need for face-to-face contact for people who are doing well on any chronic medication, not just antiretrovirals. And some clinics are venturing into alternative forms of delivery, including bicycle deliveries and deliveries to community pickup points. But again, they are in the early phases of development and now need to be urgently pushed forward and worked on to see if that can go. So these systems might well free up clinics and open up clinic space for those who really need to be there, and hopefully they become part of our practice, and we don't have to go back to seeing everybody every 2 months and writing their prescription every 6 months, and we can actually manage stable patients in a sort of more open way and sort of shifting responsibility to the people taking ARVs instead of being quite sort of paternalistic in our as we tend to be in our system. Next slide, please. So what we're hoping for is that it's true what the information we seem to be getting from you guys who have had a bit more time dealing with this epidemic than us, in that COVID-19 does not impact those with HIV physically, as long as they are not immune suppressed or do not have comorbidities. And there's a quote there which I won't read out from GNP+. Next slide, please. So the last section I want to talk about is the impact of the lockdown on individual health. There has been a marked impact on reducing socioeconomic circumstances for the average individual in South Africa. There has been a loss of jobs, or if not a loss of a job, a loss of an income. People are allowed to claim from the unemployment insurance fund, but that is usually only a fraction of their monthly income. A study I did with Jessica Hebra a few years ago showed that food insecurity in Gugulethu was already at 62% of people who were hungry a good number of nights in the week. As I said, the casual workers, domestic workers and gardeners are only allowed to go back to their jobs when we get down to level 2 of our lockdown, and we have no idea when that will actually be. We've already seen stealing of food parcels, people appropriating government assigned food parcels and appropriately robbing of food trucks, bread trucks is happening every day. And an article from Meta et al., also from Jean Neshega, who's familiar to most of us, some quotes from them saying that although physical distancing slows transmission of the virus, it's exacting a heavy toll on the informal economic and casual sector. And most of Africa's poorest citizens will ignore quarantine directives and continue to engage in communal activities to earn incomes for their families. Next slide, please. There's been a notable increase in gender-based violence, which also impacts on adherence and antiretroviral tablet taking behavior. Impact on people coming to clinics, impact on sexual health. And our social development minister has said that they've noticed this increase in gender-based violence and are not moving swiftly enough to help women to get out of abusive situations when they are basically stuck at home with these problems. Next slide, please. And this has been touched on by Bob and others. When you're talking about adherence, when people are living in tight spaces with multiple people in their homes, that lack of privacy and potential non-disclosure is going to result in poor adherence. I do have patients who hide their medications in suitcases under their beds and take it at certain times of day when their family's not in the room. And now their families have been in the room with them for the last 6 weeks. So you wonder how they've managed, or if they've managed to take their medication in that setting. There's also a fear that has been aroused because of COVID-19. And I know Bob has spoken to the mental health aspects of that, but there is actual fear of police. We've had thousands of people arrested in South Africa. You have to have the correct documentation in place to move from one place to another. People's movements have been severely restricted. People who were in the wrong province. We had a 4-day notice before we were locked down strictly, and so people were in the wrong place, were not at home. People are not attending their clinics because they have left their homes and their appointment card is not proof enough to the person at the roadblock that they need to be going to the clinic. And we at the clinics can't get people who don't have smartphones letters of attendance or saying an invitation that they need to come to the clinic. So the reaction that our government, the police reaction to our epidemic has had impacts on people leaving their homes, reaching clinics, getting their drug supplies. Next slide, please. So also with this lockdown and people being at home and not going to work, there's a change in people's dosing patterns. People's habits are altered, and it can go both ways. I have had one lady who always anxious, and she came to me and she basically said, no, my life is much simpler now. You know, she doesn't have to rush and get her kids to school. She's calmer, she feels better, and it's much easier to dose. She doesn't have to go out to work. So there are people out there who are benefiting by the simplification of life, but other people find dosing harder because they don't have those habits that they routinely dose to. So they're oversleeping, they don't have a routine. And so when you speak to individuals, they can go either way in terms of whether staying at home is actually of benefit or of harm. Next slide, please. So basically, I'm saying that the people's problems are magnified in this time of great stress. And when we're looking at the solutions, I think on the slide coming up, I have the Maslow's hierarchy of needs, and I think what we have to realize is that when people are hungry and their physical needs are not met, then taking their medications for antiretrovirals is not going to be as high on their priority list as accessing food. The government is trying to address this. There is a new social grants, which is 350 Rand a month, which is not going to go very far, but it is something. They are distributing food parcels. there's some frustration of the private sector who would also like to be distributing food parcels, but we're being told that those food parcels have to go via a government warehouse for health and safety regulations and checks, which kind of slows the whole process down when people are in need. So there's like good intentions that actually causing harm from a systems point of view. We have all been told we can't leave the house without a mask. So there are now a number of NGOs and women working together to make masks, with some increase in employment opportunities. So it's an employment opportunity that has come up for people. Next slide, please. And so what are the solutions that we can do as healthcare workers? And I think we can encourage people to collect ARVs. In my clinical trial setting, we're privileged to be able to offer people lifts. Not so easy for people in some communities. We have to educate people to dose correctly and maintain viral suppression. And like Dr. Penny, I think it's really key to educate people about COVID-19, about what works in terms of physical distancing, in terms of hand washing, hand hygiene, the addition of masks as is prescribed for us, how to stay safe while traveling and at clinic, and just to try and support people through this epidemic as best we can. And I really can't see how we are not going to have a lot of people failing treatment and moving on to second line through this epidemic. But hopefully with the mitigating factors and the positive things that are happening, we can negate some of those negatives. Thank you. I think that's my last slide.
Thanks very much, Catherine. And it was interesting to see your use of Maslow's hierarchy of needs to speak to some of the health system solutions that we should be looking at in relation to optimizing ART adherence. We're next going to move to what I consider to be a tool of equal equivalence to antiretroviral therapy, which is U equals U, or undetectable equals untransmittable. We, as an association, have been promoting its integration into clinical practice now for the past couple of years, and are doing so in partnership with the Prevention Access Campaign. But we're truly inspired by the work that is being done by so many community advocates, including our next speaker, William Matuvo from Love to Love organization in Uganda. And we've asked them to speak to U equals U as a motivational message for HIV treatment adherence at this time of COVID-19. William, the floor is yours.
This is gonna be my presentation layout. Introduction, what is U equals U? What does it mean? Glancing back and moving forward in treatment research, the impact of U equals U. As far as adherence is concerned, challenges encountered in spreading the life-changing message of U equals U. The effects of COVID-19 to the lives of people living with HIV in Uganda. What we have done as Love to Love organization to ensure that people living with HIV have access to treatment. Conclusion. Next slide. I would not take so much time to talk about myself. As you can see in this slide, that's who I am. Next slide. What is U equals U and its meaning? You could be wondering, what is U equals U? U equals U in full is undetectable equals untransmittable. And this is scientifically proven by different studies that have come up by scientists, and it means that somebody who is HIV positive and achieves and maintains undetectable viral load, all of less than 200 copies per milliliter, can never pass on the virus sexually to their negative partners sexually. So this means that the risk of sexual transmission is totally zero. Next slide. The progress of treatment research. Before I proceed further, we have been seeing a lot of progress in treatment research. In the 1996, we knew that treatment could just keep us healthy, but in 2008, a Swiss statement was issued that somebody who is effectively taking his medication very well can never pass on the virus sexually to his or negative partner, and the risk of sexual transmission is 0. But we have to glance back to see how this has been happening, to see how it came into existence and where we are right now. So as you can see that there are 2 men on your screen right now. We have Dr. Julio Montana and Bruce Richman. Dr. Julio Montana founded TACIP, meaning treatment as prevention. And TACIP was the birth of U equals U in the other way around. And we all know that Dr. Julio Montana found the landmark study of HPTN 052, which showed that somebody who is effectively taking his medication cannot transmit HIV with 98%. So we came, so U equals U came into existence by Bruce Richman, the founder of the Prevention Access Campaign and the U equals U campaign. This man knew about that he cannot transmit HIV sexually in the year of 2012. So he came to know about this in 2012. So this means that we are progressing in terms of treatment research, and we are seeing where we're going. Next slide. Sorry. In this slide, we have seen a number of endorsements by different scientific people, but this I liked so much this slide of Dr. Fauci, Anthony, whereby he said that the U equals U is the foundation to be able to end the epidemic. You're gonna watch this video. It's like 1-minute video, then we proceed further. Next slide. We are going to discuss about, okay. On this slide, I'm going to talk about the impact of U equals U as far as adherence is concerned. First and foremost, when people know about U equals U, basically the discordant couples, it creates harmony among them, hence adherence. Another thing that U equals U dismantles internal and external stigma. And this means that if stigma is not within some people or within the community we are staying in, it means people will be adhering well to their medication. U equals U also prevents clients from defaulting their treatment. It means that they will be taking their medication very well because they heard about the good news of U equals U. Next slide. Challenges encountered while spreading the U equals U message. Number one is HIV colonialism. What I'm trying to mean about HIV colonialism, it is withholding vital information about HIV. When I began spreading the U equals U message here in Uganda, we faced this similar challenge. There is a lady from the US who's who wrote to us and told us that we should stop saying this life-changing message to spread it to other people, of which we stood on our thoughts, and we say that we should not stop spreading this message. And eventually it led us to lose funding, because that lady could fund us to support the charity work that we do here among young people and children living with HIV in Uganda. So another problem that is hindering the spreading of U equals U message is financial support. If at all U equals U could have reached very far, if at all they could have funded this project or this campaign. So as advocates, we really need more funding in order to spread this life-changing message, because we all know that when the people learn about this message, they will adhere well to their medication. Thirdly, dogma naysayers. This has also hindered the spreading of U equals U message everywhere, basically here in Africa, because here people think that things have to be like that forever and ever, yet science is dynamic. And another thing, point number 4, most people think that this campaign is only in the favor of the LGBT community. We have experienced such because people think that because the founder of this campaign is a gay man, so they think that it is promoting homosexuality. Basically, this kind of thinking is so much into Africans. Next slide. Mr. José had asked me about a question about how COVID is affecting the lives of people living in Uganda. Of course, I've been watching news here in Uganda. People have failed to access treatment because of long distances and ban of public transport. So this has also caused a setback in adhering well to their medication. And another thing is people are still in a lockdown, and our president a few days ago extended the lockdown to more 14 days, of which we have spent like 1 month and 2 weeks. So he added on another 14 days. So people are starving here in Uganda. People are leaving medication because they lack what to eat in this period of COVID-19. Though the government has been trying to give away food, but it is not enough. So I and my team, we decided to begin a campaign, a fundraiser campaign, whereby we can fundraise money for our fellow brothers and sisters living with HIV here in Uganda, because we have got a lot of messages in our inboxes. People are crying. People are saying that we are going to stop treatment because we have nothing to eat. Yet we all know that without food, treatment cannot be taken very well. Next slide. What we have done to ensure that people living with HIV have access to treatment. We have, in our own capacity as Love organization, we have introduced, in partnership with the Live Alive Network, we have introduced a bicycle initiative whereby volunteers come in, use their bikes, and go fetch treatment for those who can't go to clinics in this lockdown. So that's what we have done so far. But if there is somebody who can donate a bike, a motorbike, it could ease the work, because we receive calls from different distant places where we can't reach because we use energy while riding these bikes. Next slide. Conclusion. In this statement I'm going to read, in order to ensure that all people living with HIV are happy and healthy, we must embrace the you equals you message because it motivates many lives of people living with HIV to adhere well to their meds. As a matter of fact, you equals you opened our eyes. Now we really know the benefits of our treatment. So my emphasis is we should continue spreading this life-changing message in order to encourage and save more lives of our brothers and sisters. But still, to achieve this, we need support. We need to support each other for this noble cause. Next slide. If you want to know more about me and our organization and the work we do and some source links where I've got some of the information, you can follow those links. You will be able to contact me or our organization. I'm very, very happy to be on this podium tonight to do this kind of presentation. And I look forward to the upcoming conference. And if at all I'm given an opportunity, I'll be singing for you live because technology is not giving us things well. But I think thank you so much for all the presenters who have been doing a wonderful job, and International Association of Providers of AIDS Care for initiating this kind of initiative. Thank you so much.
Thank you very much, William, and we really are looking forward to seeing you at the Adherence 2020 conference, God willing, in November of this year. So, you know, you and your compatriots have started a revolution that I think we all need to join and make sure that this life-saving and destigmatizing message is heard loud and clear. The evidence is firmly behind it, and we need to support it in every way possible. So thank you so much, and please stick around if you can for the question and answer session. We're now going to start the last presentation in this section. We've asked Marianne Torres from the International Council of AIDS Service Organizations in Canada to speak to us about communities as pathfinders in humanitarian emergencies. So I'll turn the floor over to Marianne for this final presentation. And as previously noted, please submit your questions so that we can ask our three speakers here to address them before we close the virtual conference. Marianne?
Hi, good afternoon. Can you hear me?
Yes.
Yes, we can.
Perfect. Thank you. Good afternoon, everybody that is online in these very strange times. Thank you to the organizers for taking this topic into consideration for this webinar or this advanced feature of what is coming in November when we all meet in Orlando. I will attempt to summarize a very complex situation in a short presentation. I will be speaking about the complex humanitarian emergency in Venezuela, presenting some key indicators that tell the story of everyday Venezuelans. I will also talk about the leadership role of civil society organization and the results to date that in no way represent the comprehensive response that we need. So let me start by describing the complex humanitarian emergency in Venezuela and the health crisis within this humanitarian emergency. I will then illustrate how the emergency has impacted the AIDS response. And then I will highlight a few examples of how the leadership and resilience of civil society, communities, and people living with HIV have improved the life of thousands of people in Venezuela. And I will end the presentation by providing key recommendations and thanking our partners. Despite having the largest oil reserve in the world and one of the largest gold deposits, and being one of the wealthiest countries in the Americas 15 years ago, Venezuela is confronting a complex humanitarian emergency. Besides high level of malnutrition reported by the FAO a few months ago, and escalating poverty, around 87% of households were in poverty in 2018, the health system has collapsed. This is an atypical crisis that has not been driven by armed conflicts or natural disaster that, like most. It is a result of political tension and implosion of the economy with the hyperinflation, severe shortages of many basic items, including food and medicine, and very high level of corruption, violence, and crime. Despite this, the Venezuelan government denies the existence of a crisis and rejects the President of the Security Council said yesterday, it started well before COVID-19, and it was not caused by the sanctions imposed on corrupt government officials charged with human rights violation and other crimes. In October 2019, ACAPS published this analysis showing the degree of and complexity of the crisis in Venezuela. And you can see that in this slide, the crisis severity is very high, the impact is very high, the humanitarian conditions are very high, and the complexity is very high. It is affecting the whole population of Venezuela, which has been calculated at almost 29 million people. I wanted to show this slide just to emphasize that the humanitarian crisis in Venezuela is real and is official, as it is recognized by the United Nations. I also wanted to show it that because of the totality of humanitarian projects supported by the UN Offices of Coordination of Humanitarian Affairs, or OCHA, in the country, 68% of those projects are managed by NGOs, highlighting once again the important role of this sector in humanitarian emergencies and responses. More on this later. For the last 4 years, we have seen an increase in shortages and stockout of most medication, from aspirin to morphine, antiretrovirals, and antibiotics. Now, let me pause here for a moment. The fact that the data we are getting from the government is not reliable or doesn't exist makes our social monitoring initiative and the role of civil society as watchdog even more relevant and more important. I will go into some details in a few minutes. Let me emphasize that the government has not published any epidemiological information since 2016. The provision of drugs and strategic supplies for public health programs is one of the country's biggest challenges. There is a critical stockout of essential drugs for HIV and sexually transmitted infections, opportunistic infections, preventing congenital syphilis and malaria treatment. There are also no diagnostic or monitoring tests, insufficient reagents and supplies for laboratories and blood banks, and insufficient vector control supplies for malaria, for example. This is due to a number of factors, including lack of funding, fragmented supply management, lack of domestic pharmaceutical suppliers, insufficient internal controls. Additionally, more than 22,000 doctors have fled Venezuela, representing around 65% of all specialists. Now, maternal mortality is widely accepted as a key indicator of health and socioeconomic development. This slide shows the increase in maternal mortality rate in Venezuela. The red line is based on official government data. And it is also shown the last year the government published information, as I mentioned, 2016. This resulted in the firing of the Ministry of Health that year. You can see the rapid increase between 2014 and 2016, and what experts have estimated for 2017, 2018, and 2019. So, of course, the HIV crisis is not independent from the overall humanitarian emergency we are living now, or the crisis of the health sector as presented before. What is perhaps different is the role of those affected, people living with HIV and their families, organizations, and networks. in responding to the crisis. I will discuss the resilience of civil society in a few minutes. Based on official data shared by the National AIDS Program, but not published, in 2018, there were 4,000 new infections, of which 26% were women. In 2019, while no total number of infections was ever presented, 46% of new infections were women. This graphic shows a steady increase on the number of people living with HIV. And alarmingly, as reported by UNAIDS, during the same period, a 7% viral suppression rate. And we just heard how important our U=U movement is. In this graphic, we can see a steady decline of availability of ARVs between 2012 and 2018, with a critical point in 2018, where our community monitoring initiative was able to document a stock out of 84% of our antiretrovirals. Our partners have been raising the alarm since 2015, writing to the UN and the Global Fund for support. Finally, the Global Fund accepted our petition and provided emergency funding for 2019 and 2020. The first $5 million were used to purchase TLD, which is tenofovir lamivudine in the dolutegravir, in 2019. And this is the rebound you can see after 2018, getting to 40% in 2019. Now, availability of ARV is only one aspect of the HIV crisis. There are no diagnostic, there's no viral load test, no CD4 count, no treatment for opportunistic infection or condoms. Women living with HIV are forced to deliver their babies. No C-section is offered, and no treatment is available for them or their babies. Additionally, no formula is available. The data presented in this table was presented by the National AIDS Program at the end of 2019. This is a screenshot of their presentation. This is the total at national level of new cases disaggregated by age. So it's 5 years, 5 to 9, 10 to 14. The National AIDS Program is reporting a 10-fold increase on the total new cases of HIV in children in 1 year. This is a clear indication that our health system is really in shambles. So, what has civil society done, which is the main topic of my presentation? Let me summarize our actions in 3 main points, reflecting on Dr. Harris from UNAIDS presentation earlier today. In regards to community-led services, so we can see that I have divided how civil society has worked within the humanitarian emergency in 3 topics. One is community-led service delivery, the second one is community-led monitoring, and the third one is community-led advocacy. In regards to community-led service delivery, communities continue to respond. From HIV prevention through treatment to care, community groups in Venezuela have been at the forefront of providing this to people living with HIV. For example, the only condoms that arrived in the country in 2018 were procured and distributed by community groups. At the end of 2019, 20,000 diagnostic tests were procured and are currently being distributed by civil society. And these are the only diagnostic tests available in the country. The Network of People Living with HIV, or the RVG, currently has a program of navigators to ensure linkages to care and treatment for people living with HIV to increase adherence. The navigators go to an HIV care and treatment service where they interview people living with HIV and provide guidance and advice in different aspects related to their personal situation, health condition, among others. In some instances, this work had to be done almost underground because health personnel, following direct instruction from the Ministry of Health, restrict or refuse access to the health facilities. Now, civil society has been systematically documenting the parallel and concurrent crises. In particular, I would like to mention the work civil society in the HIV field has been doing, led by the network of people living with HIV. Our civil society partners have been able to monitor and document almost in real time the availability or lack thereof of ARVs in the government pharmacies. This data collected through a robust method and a comprehensive mechanism has been used, among other platforms, to convince the UN system and the Global Fund of the situation in Venezuela of over 80% stock out of ARVs, as we saw before. We have received now $11 million to purchase ARVs and limited quantities of anti-TB and anti-malaria medication, plus very limited viral load test reagents. This same method of monitoring has been used to monitor the availability of personal protection equipment to respond to COVID. The systematic documentation mentioned above has served to advocate with reliable and credible data for the international community to invest in solutions to the crisis. Let me focus on two key results of this advocacy. As I mentioned before, the decision of the Global Fund to approve funding to address the health crisis in Venezuela for a total of 11 million, 5 million in 2019 for TLD, and 6 million for 2020 for HIV, TB, and malaria commodities. These amounts also support efforts by civil society to monitor the implementation of these resources. But $11 million for the three diseases is by no measure enough. Based on recent calculation contained in what is known as the master plan, developed by a multi-stakeholder group in 2018 and revised in 2019, the need is more than 122 million. Of course, this is a very conservative estimate when you consider the situation of the health and other infrastructure in Venezuela, like transportation, for example. Additionally, these estimates are based on needs assessment using mostly government data that at the very best is unreliable. Let me also mention that the Global Fund has decided that Venezuela is now eligible for the malaria component due to the resurgence of the disease. And while we may celebrate this, it is also very sad for Venezuelans to accept the fact that our malaria response, the best in the region and one of the best in the world, 30 years ago, is in shambles, and as is the whole health system and the country in general. So, from New York to Geneva, through Washington, Amsterdam, Bogota, Mexico, and Paris, and now here online, and of course in Venezuela, our partners have met with global and regional leaders, have spoken at conference, UN meetings, including the UNAIDS PCB, to denounce and condemn the lack of government action and their unresponsiveness to the health crisis. The data collected and analyzed has been used in these different settings to advocate for attention to the situation in Venezuela. Some have done it openly. Others have preferred to remain underground for fear of persecution by the government. Venezuela is confronting a well-documented, complex, man-made humanitarian emergency, made worse by a deepening social and economic debacle, including that there is no cash or gas, there is a currency-free, record-high inflation, food insecurity of millions, a health system that is destroyed, massive migration, including of doctors and other health personnel, stock out on medication, and now COVID. And this in an environment of political disarray, disregard for human life, high level of violence, and daily gross violation of human rights, including of our partners in the country. However, these community partners continue to play their role, ensuring access to treatment by avoiding treatment interruption, and we have heard some examples from around the world on how the National AIDS program or the National AIDS response is accommodating new mechanisms to ensure that people living with HIV receive their treatment. but also by ensuring people living with HIV have food on their table. Also, securing personal protection equipment for those working on HIV, and of course, documenting, and advocating, and denouncing. The picture that you see there is the network of people, members of the network of people living with HIV, distributing PPE in some hospitals outside Caracas. In conclusion, the gains that we have made with HIV, even those recent in Venezuela, are at risk to be lost. And now we have increased the risk of multiple epidemics, including an even bleaker situation for malaria. It is important that we address structural issues, including support communities on the ground, an effective system for rapid international support for community responses in crisis situations. The key needs for support are, based on our own monitoring, we need to have international systems to build and support local skills for supply chain and risk management, particularly for communities. We also need an international system for emergency support that goes beyond the work the Red Cross and Doctors Without Borders are doing saving lives in Venezuela. Finally, we need better and more effective intersecting and transdisciplinary responses that bring together, in the case of Venezuela, COVID, malaria, HIV, nutrition and physical well-being, migrants, prisoners, TB, human rights, key population. Also, we need to remain vigilant of human rights and how governments are using these crises to continue violating our basic rights. So in closing, the first step is a mechanism. We need a mechanism to support community systems in emergency situations. Let me finish by acknowledging our in-country partners, in particular ACSI and the RBG, for their commitment to a better Venezuela. And two of my colleagues, Ken and Leopoldo, for their support in developing this presentation. If you want to know more about the humanitarian emergency in Venezuela, the situation of people living with HIV, and the role of the community sector, please visit the Venezuelan section in the ICASO website, www.icaso.org, and check all the documentation we have been able to compile. And of course, feel free to contact me at the email above. Thank you.
Thank you very much, Marianne. I mean, I think your message of the importance of community to serve as watchdogs is really important, to document, advocate, and denounce where necessary the inability or unwillingness of our elected officials and others in positions of power to do what they should do for the good of the people, the right of the people to health and other social benefits. So thank you very much for that presentation. With that, I'd like to open the floor up to questions from our attendees, and we'll start with the first three I have in front of me. Two are directed at Catherine. So Catherine, are you ready? The first, can you expand on the Adherence Club intervention you shared? And second, what could be a possible clinical trial to check the CD4 count and viral load impact on COVID-19?
Yes, thank you. So the Adherence Club model has been running for a number of years now. Essentially, at this point in time, people who are virally suppressed, and that can be at their first viral load, which is 4 months into treatment, or their annual viral load, which happens thereafter, are offered entry into an adherence club. These clubs are between 10 and 30 people, usually closer to the 30 people's number, and they meet, depending on the clinic, off-site. So, for example, where I work in the Guguletu Community Health Center site, the clubs meet down the road at a community center that is not linked to the clinic. And the counselor who manages the club essentially picks up pre-packed medication from the pharmacy and delivers that to the club. They're then supposed to be weighed. Everybody is weighed on the day, and the counsellor is supposed to give a talk about adherence and garner everybody's how they are and how they're doing. So they meet 5 times a year. It's every second month, and then 4 months over the December period, because many people go away, and we're trying to reduce that. MSF in Kailicha with Tali Cassidy have been looking at meeting every 6 months, giving 6 months drug supply. 1 visit per annum would have to be a clinician visit with a nurse practitioner to draw bloods, and the rest would be routine visits with viral load drug supply. So it is a way of differentiating care, removing people from the clinic floor and keeping your stable patients in out of the clinic system, giving them more independence and responsibility for their own health. So that's the club system. And then there is quite a lot of surveillance going on currently within the Western Cape for HIV and COVID. So I think we will learn about the impact of COVID on people living with HIV by CD4 counts, by viral load. We're all aware that this is, a potentially huge problem issue, and the Provincial Department of Health is conducting house-to-house testing at the moment, where they are also doing rapid tests for HIV and encouraging people to access treatment during that time. We will also have a protocol looking at household surveillance, looking for TB, looking for HIV in process from our own units, and certainly our Groote Hospital Testing Centre. There are a number of people who are interested in the epidemiology of COVID-19 in people living with HIV. There are studies looking at both prevention in healthcare workers living with HIV, preventive treatment for COVID, as well as early treatment protocols, all coming up and in place at the moment. So I think it is knowledge we will know over the next few months.
Thank you very much, Catherine. William, we have a question for you, which I think you're going to get into in greater detail at the Adherence 2020 conference in November, but it, in essence, is there a results framework around the U=U movement? And if so, what are some of the outcome indicators?
Come again? Hello?
In essence, the question is around whether a results framework surrounds the U=U movement, and if so, what are some of the outcome indicators?
The framework?
Outcome indicators, indications of outcomes that are as a result of, we've been looking, for example, at whether it breaks down barriers to actual utilization of health services, treatment adherence, those sorts of things.
Actually, here in Uganda, so far what I've seen, U=U is changing people the lives of people living with HIV. I normally give myself an example. Of course, I've been in advocacy for some good time, since the age of 16, but I had come out publicly, yes, but still I had a little bit of stigma within me. But once I landed on this kind of information of U=U, automatically it changed my life. I didn't know that people living with HIV, when they go into sexual intercourse with anybody who is negative, they can't transmit HIV. Because here in our clinics in Uganda, what they normally tell us that if you're HIV positive, you're not advised to marry somebody who is HIV negative, you have to look for a person of your same status, of which now at this point U equals U is perishing, is washing away that. So people have been motivated to take their medication very well, and in the other way around, people love the fear of transmission has caused the fear of transmission is no longer there, because now people love people of their own choices.
Thanks very much, William. And as I said, I think you'll be going into greater detail into this process that is ongoing amongst the U equals U community. I know the Prevention Access Campaign has been looking at specifically indicators to report beyond the anecdotal, what in fact is the impact of U equals U on service utilization and HIV outcomes. Marianne, the question I have before me is for you, and I'm guessing someone figured out you're a lawyer on top of everything else, and it speaks to the fact that governments are taking unprecedented emergency measures that place far-reaching restrictions on people's everyday lives. The question is, should there be at some point in the future a review of these restrictions and sanctions against any government that enforces emergency measures unfairly or creates additional inequities in access to health and other services?
Yes, I'm a lawyer. I didn't know that it was so evident. You know, like in the case of Venezuela, and I see it, I live in Canada, but in the case of Venezuela, we know that part of the monitoring that we are doing there is exactly on the far-reaching power of the government. We have focused on how some of the measures that the government has taken are impacting health, and there are a few things. So specifically on HIV, we have been documenting some of the policies or decisions on transportation and crossing from one municipality to the other. For most people, accessing ARVs, they have to cross at least one, if not 2 or 3 municipalities, and sometimes they have to travel outside their home state. So we have been documenting that, and we have been working with both UNAIDS and PAHO in the country to ensure that that the restriction in movement in Venezuela are not having an unwanted impact on people living with HIV. So that's one thing. The other thing that we have been doing, particularly around the human rights mechanism in the Americas, is also documenting human rights violations. And the plan is, as we have been doing for years now, is to provide that information not only to the Inter-American Court or the Commission of Human Rights, but also to the Office of the High Commissioner on Human Rights in Geneva. Because I think it's very important that while we are looking at you know, how COVID is a health problem, is also being used by a government as a political problem, and how they have, in the case of Venezuela again, how they are putting reporters in jail because they have challenged the numbers that the government is providing around new infections or deaths. And that has been the case for a long time with doctors. Given that the government doesn't give any type of epidemiological data since 2016, doctors are very afraid of, saying anything around cases of either being HIV. There were a few cases or, suspected cases of polio that nobody knows what happened. The situation with the indigenous people and malaria, for example. Nobody wants to talk about it because people are afraid. Some of our own partners were harassed, and a couple of them were kidnapped by the police because they were speaking about the situation of access to ARVs last year, and we were very public on that. And I think that, Shannon said something earlier today about solidarity, and I think that's the role of those of us that are outside the country, that can speak freely, that can put our face out there and our voice out there without fear of violence or persecution. And that solidarity, together with, global advocacy and networking, I think are, what we need to ensure that, the international law system responds accordingly to the times that we are living.
Thank you very much, Marianne. We have come to the end of our question and answer session with no other questions. I know that this has been a long program, so I want to take a minute now to thank our faculty for this section of the program. And we look forward to seeing you hopefully in November in Orlando at the Adherence 2020 conference, where we have many more such quality presentations focused on the various elements of the HIV care and prevention continuum. We're ending a little early, and so I'd like to thank each of you for your time, and of course each of you for the amazing work you do, both in response to HIV, but of course at this time in response to the COVID-19 pandemic. These are not easy times for any of us, and I wish to thank you. I also wish to thank our distinguished faculty, my staff that helped put this virtual conference together in such a short amount of time, as well as our sponsors, Gilead Sciences and ViiV Healthcare and the Fast Track Cities Institute. I'd like to end on a personal note of reflection. We, especially on weekends, have so much time on our hands to reflect, and we require distraction to not allow ourselves to go crazy thinking about the what ifs. And during this time, I've spent reading about the Spanish flu of 1918, and one particular sermon delivered by a minister here in Washington, D.C. back then really caught my attention, and I thought I would share part of it with you because in many respects, we within the HIV community have endured much of the same pain and suffering that other generations have experienced through multiple pandemics, COVID-19 being just the latest. And he said, now that the worst is over, I've been thinking, as doubtless you have all been, of these calamitous times through which we've been passing, thinking of the large numbers that have been sick, the large numbers that have died, the many, many homes that have been made desolate, the many, many bleeding, sorrowing hearts that have been left behind. And I have been asking myself the question, what is the meaning of it all? What ought it mean to us? Is it to come and go, and we be none the wiser or better for it? I'm convinced, based on the discussions we've had today, but also the incredible experience over the last so many years of the HIV pandemic, that this will not be for naught, that we will learn valuable lessons, and it's important, in part, valuable lessons from the HIV response that will help us be better prepared for a pandemic we well knew was coming, but unfortunately did not plan for as we should have. So with that, I close and wishing you all safe health for you and your families, and a sincere hope and desire that we're able to be together again physically in the very near future, if not at Adherence 2020, then at some other conference. Again, thank you and take care.
Likewise.
Thanks, Jose.